start on time on behalf of the team because there's a packed agenda. And as I've mentioned to a couple of you, I'm sort of pretending this is a large living room. And we're all friends here. Some of us know each other already, and some of us don't. Just take a deep breath. So, I'm Leisher. I am the co-director of the University of Utah Stillbirth Center of Excellence. We call it USCO. I'm also a stillbirth epidemiologist, and I'm a global stillbirth advocate, but most importantly, I'm the mother to Wilder Daniel, my first child, who was stillborn at 30.5 weeks in 1999 with no cause found. And so Wilder is the reason that I am here today. It's funny. For the parents in the room, you understand, and for the caregivers in the room, you also understand how sometimes even 26 years later, and it's getting me right now. Anyway, on behalf of my amazing co-director, Dr. Bob Silver, who isn't with us right now because he is delivering a baby, a rainbow baby, and also on behalf of our wonderful team at USCO, I am honored and thrilled to welcome you all to the second annual Stillbirth Symposium, Closing the Gaps. USCO's mission is to be a national and a global leader in the fight to end preventable stillbirths, delivering excellence in clinical care, bereavement support, research, advocacy, education, and yes, equity in health outcomes. We see today's symposium as an integral part of that mission, bringing together clinicians, parents, policymakers, researchers, and other stillbirth stakeholders and allies, very much in the tradition of the International Stillbirth Alliance, for those who know ISA, for this day of learning. Today, our day is focused mainly on moving towards a stillbirth bereavement care pathway with equality and equity. It's my honor to offer our heartfelt thanks to the generous donors and sponsors who have made today's gathering possible. Your support has helped to create this space of remembrance, healing, and advancement in bereavement care. A special thank you to the Mower family, whose meaningful gift is given in loving memory of Riker Mulholland. And to the Stetler family, whose generosity and fellowship we greatly appreciate. We also extend our thanks to our corporate sponsors, Young Living, Cozy Earth, the Grand America Hotel, and Larkin Mortuary. To all our sponsors, your contributions are acts of care and love, and we are deeply grateful. Next, I'd like to acknowledge two aspects of my own identity that affect my work on stillbirth, and hence my role in today's symposium. First, as a white person, I acknowledge that I am inherently part of the white-dominated society that created and perpetuates the very structural racism that is part of the inequities we will be learning about and discussing today. And secondly, as the mother of a stillborn baby, I unfortunately bring an insider's perspective to stillbirth. I'd also like to share a disclaimer that the opinions expressed during today's Stillbirth Symposium by University of Utah employees are their own. With that said, I'm now glad to provide a land acknowledgement. The University of Utah has both historical and contemporary relationships with indigenous peoples. Given that the Salt Lake Valley has always been a gathering place for indigenous peoples, we acknowledge that this land, which is named for the Ute tribe, is the traditional and ancestral homelands of the Shoshone, Paiute, Goshute, and Ute tribes, and is a crossroads for indigenous peoples. The University of Utah recognizes the enduring relationships between many indigenous peoples and their traditional homelands. We are grateful for the territory upon which we gather today. We respect Utah's indigenous peoples, the original stewards of this land, and we value the sovereign relationships that exist between tribal governments, state governments, and the federal government. Today, approximately 60,000 American Indian and Alaska Native people live in Utah. As a state institution, the University of Utah is committed to serving Native communities throughout the state in partnership with Native nations and our urban Indian communities through research, education, and community outreach. So you should all hopefully have a program. See that? Yeah. And you can see that it's a super packed agenda. So to respect the time of our presenters and also our own time, we're going to do our best to keep to the allotted time and keep moving forward. If you find that you have questions or comments that are remaining unanswered, please just check in with us at breaks or afterwards. We will have a short break for coffee in the morning and afternoon with a longer break for lunch. Today's symposium ends at 5 p.m., following which we will have time for networking before our series of evening workshops beginning at 5:30 with a simple dinner for those who have registered. So a bit of housekeeping. The bathrooms are outside and to the right. There's a lactation room also outside and to the right. I think it's room 1640. Yeah. And we have a quiet room that's sort of set aside for parents, family members, support people. If you find it to be that you need to step out for any reason, please feel free to use that room. It's outside to the right, all the way at the end of the hall on the left, past the university store. Let's see. I can't hold the mic and turn the page at the same time. Should have thought of that before. So yeah, and also finally, many organizations have brought things to share that are outside on some of the round tables. So please, during the breaks, go and have a look and see what you find there. I want to also acknowledge that we will be having some photos of stillborn babies throughout the day up on the screen. We will let you know when those come up, before those come up, in case you need to look away or step out. So with that, I think I've covered everything. Everybody should have a program. You should have one of the votive candles. Sorry. Okay. Yeah, go ahead and hold it up. Yeah, that's what you should have. So maybe folks like Ashley, you guys can run outside now and bring in some of the other ones, and we can hand them out to whoever wants one and doesn't have one. You should have a program and a name tag. That's it. So with that, I'm going to hand it over to Stacey Fletcher. Stacey is the program manager for Parent Voice at the University of Utah Stillbirth Center of Excellence, and she's an absolutely vital part of the work that we do, and she's going to lead us in the next session. Thanks, Stacey is the program manager for Parent Voice at the University of Utah Stillbirth Center of Excellence, and she's an absolutely vital part of the work that we do, and she's going to lead us in the next session. Thanks.
I'm a podium girl. Is this working? Yeah? Okay. Oh, here's your mic.
Not sure.
Is that working? Ah, that's better. Okay. My name is Stacey Fletcher, and I have the honor of working at the Utah Stillbirth Center of Excellence as the program manager of Parent Voice. My son Benjamin was stillborn 19 years ago. My job is to speak about and advocate for lived experience in this important work. I work as peer support in the Utah Pregnancy After Loss Clinic. It's an honor to support our clinic families who are on a terrifying and hopeful journey through pregnancy after loss. After the U.S. Pregnancy After Loss Network, our clinic is the third in the country to provide this amazing care. Our network has 6 additional clinics in the process of opening across the country: UCSF, UCLA, Yale, Penn State, the University of Hawaii, and Intermountain Health, another clinic here in Utah. This network will both save and change lives. At the University of Utah, I am part of a parent clinical training team to instruct clinicians and staff members about this pregnancy after loss model of care. I also get to share the experiences of many parents whose babies have died during pregnancy or shortly after birth. I have the honor to tell their stories and help improve care for the many parents in the future who will unfortunately join us as bereaved parents. Under the U.S. PAL network, I'll be visiting these clinic sites and deliver training to rooms of physicians, nurses, MAs, sonographers, researchers, reception staff, scheduling centers, social workers, chaplains, medical students, residents, mental health professionals, and parents. It is one of the greatest honors of my life. I think of the time so many years ago that I spent with little Benjamin and the gift of his life, the life that changed the trajectory of my own. Never would I have believed in that moment that I would be standing here before you today. Over the years, I have sat with many families who were just beginning on their own journey, on an unexpected road of grief. I've been invited into the most vulnerable and sacred experiences with these babies and families. It's a treacherous journey with so much sadness, deep grief, and unexpected gifts along the way. The days and years following the death of a baby can be very dark. When sparks of light begin to return, they often come with both hope and fear. The light is a lifeline to bereaved parents. It is a memory of our babies who we carry in our hearts. Today, I want to honor this light and remember the reason that we're gathered here today, the babies who left us too soon. One of my favorite quotes is this: "I will never forget those who came with a lamp when I was in the dark, not to fix me, just to sit beside me until I could see again." That is our role in this work. We have the opportunity to bring light to grieving parents, to new research, to advocacy and awareness, to education and training, to inclusion and marginalization, and to exceptional clinical care. Our light pierces the darkness, but many lights shine a pathway of change and equity. We do not have a long time this morning, but there's power in a room full of people gathered for a cause. We want you to know who is in the symposium today. We will provide a microphone for you, Sue. It's going to start. We're going to provide a microphone for you to tell us your name, your position in your work, and if you're a bereaved parent, family member, or friend and would like to share, to say the name of the baby that you represent here today. We then invite you to light the candle that you were given when you entered today. If you did not receive one, please raise your hands. I think we've got, there's a couple here. We hope you leave enlightened, challenged, and motivated. It is our honor to share this space with you. I light my candle. For my two babies, Lee and Benjamin Fletcher. Should we start in the back?
Okay. Hi, everyone. I'll keep this short and sweet so we can get through with introductions like Stacey mentioned. My name is Sunayna Wahi. I'm a senior research manager in the OB department here at the University of Utah. I'm a lost mom.
Hi, my name is Brittany Crystal. I'm the founder of the Iris Fund, mother of Iris, who is still my stillborn baby. She is 8, and a founding partner of the UPAL network.
My name is Kevin Yost, and I'm a fourth-year medical student going into obstetrics and gynecology next year.
My name is Felipe Aguilera, and I'm a postdoctoral researcher at the University of Wisconsin-Madison, and I am a sister to Maria and aunt to Sophia.
I'm Kim Coates. I'm a clinical leader at my hospital in the OB department, and I am a lost mom.
My name is Jen Zaga. I am a birth and postpartum doula.
My name is Joey Morgan, and I'm also a birth and postpartum doula.
Excuse me, my name is Hannah Melstein, and I'm a social worker in women's health, and I'm a lost mom too.
I'm Taylor. I'm also a social worker specializing in women's health.
I'm Jasmine Moss. I'm also a social worker in women's health.
If you guys want to light your candles when you introduce yourselves, we'll keep them lit.
Diana Aguilera, social worker in women's health.
Missy Bradshaw. I'm a NICU nurse at Women Regional. I also work with Angel Watch, and I'm a bereavement specialist, and I'm a lost mom also.
My name is Jessica Babbitt. I'm a physician assistant at HMHI, working in the perinatal mental health team. I'm Lee Fletcher. I'm sibling to Benjamin and Lee Fletcher.
My name is Millie Fletcher, and I'm sibling to Benjamin and Lee Fletcher.
And I'm Zan Leisher, and at the University of Utah, and I'm the mother of Wahi and Dan.
I'm Jamie Bates, and I am the mother to James, who turned 16 this week.
I'm Melannie Green, and I light my candle in honor of my sons, William and Maximus. We will live life to the max.
I'm Dale Thompson. I work for OBGYN and lots of contracts.
Say y'all, Mom, I'm a researcher in Stillbirth here in OBGYN.
I'm Jessica Clayton. I am a lactation consultant here at the University of Utah, and I'm here in honor of Eliza Pitt.
Stacey Breeze, women and newborn research representative.
Kathy Meadows, research nurse with Intermountain Health in Ware.
Deanna Magana at McKee Hospital, Women and Newborn Research.
I'm Sandy Dillerman. I'm MFN research at McKee Hospital.
Kristen Orton, a NICU nurse at Women and Newborn Research at
Rachel Moore, I'm a research coordinator at Utah Valley Hospital.
Nicole Sherman. I'm a labor and delivery nurse and bereavement coordinator at IMC.
Adrienne Morrow, a marriage and family therapist specializing in perinatal mental health at Tanner Clinic.
I'm Cindy Bray, just moved to Utah now, so labor delivery nurse. Raquel Alfaro, I'm a doula and postpartum doula. Lighting my candles bay for Timber Barker and Samantha Alfaro. Robin Carter, birth and postpartum doula, and I light my candle for my granddaughter Elizabeth.
Meredith Ashton, I'm a birth and postpartum doula, and I'm lighting my candle for Ella Wyrick, my best friend's girl.
I'm Caitlin Winston, and I'm a birth and postpartum doula as well, and I'm lighting my candle for baby August.
I'm Stacey Hamilton, and I'm a labor and delivery postpartum doula.
I'm Morgan Ship, and I'm a student midwife.
I'm Brianna Hazelwood, and I'm a licensed direct entry midwife and volunteer on the infant mortality review.
My name is Kara Leonard, and
I'm Amy Salzman. I'm an epidemiologist with the Utah Department of Health and Human Services and also a LOSCOM.
I'm Heidi Sylvester. I'm a midwife working in the Department of Health and Human Services, and I'm aunt to Matthew.
I'm Susannah Smith. I'm Utah's
perinatal mortality review coordinator.
Anyway, that's it.
I'm Danielle Larson. I'm also with the Department of Health and Human Services. I'm the data manager for the Utah Solar Survey.
I'm Jane Rollins. I'm the Share Parents of Utah that provides pregnancy and infant loss support, and I am the mother of Garrett.
I'm Sarah Henderson. I'm also a Share Parents of Utah. I'm the mother of Carolyn and Linda.
I'm Vicki Angelich, and I'm with the Utah Department of Health and Human Services.
I'm Melissa Anderson, and I'm with Larkin Mortuary.
I'm Jalen Olson. I'm a licensed clinical social worker, former director of Angel Watch, and currently in private practice with perinatal loss and grief.
I'm Carolina Barra. I'm working in parental care, and I'm the executive director.
I'm Natasha Pond, and I am a doula.
I'm Leanne Johnston, and I'm one of the team members in the OB/GYN department working on
Ashley Joseph, I'm a clinical research coordinator with the university.
I'm Sarah Lopez. I'm sure you all have met me at some point via email, but I run the Stillbirth Center of Excellence Research Program.
My name is Kathleen Massmann. I'm a perinatal bereavement specialist and clinical counselor and bereaved mother to Jacob, Amadea, and Ryan.
I'm Jessica. Coordinator here at the
My name is Naomi Ridges, and I'm a researcher up here at the
My name is Haley Critchfield, and I'm a birth and postpartum doula.
My name is Lauren Davis, and I am a birth, bereavement, and postpartum doula, and a lost mom as well. Today I'm lighting my candle for my own babies and for Lemon Poppy.
I'm Joy Capsis, nursing manager over at University of Utah Outpatient Clinics.
Hi, my name's Aubrey Rasmussen, and I am a nurse here in Women's Health and the bereavement coordinator at the
Hi everyone, I'm Kathy Schreiber. I'm the hospital chaplain at the University of Utah Hospital that oversees the women's and children's areas.
I'm Stacey Francis.
I'm Finley Knowles,
And I am a
parent,
a bereavement and parent support specialist.
I'm Teddy Palmer. I am also a lost mom to Ethan and a bereavement specialist.
And I'm Ashley Home, bereavement support specialist for Mount Health in Utah County, and I light my candle for my son, Kingston.
Good morning. I'm Astrid Woodward, former L&D nurse, current internal medicine nurse with the Pregnancy After Loss Clinic, and I light my candle in honor of all of the stillborn births I've attended. I'm Stephanie Sanchez. I'm the nurse manager of the Maternal Fetal Medicine Clinic at the U, and I light my candle for my baby.
I'm Brenda Gulliver. I'm a previous labor and delivery nurse and work clinical programs, specifically the UPAL clinic here at the University of Utah. And I light my candle for all of us. Thank you so much, everyone.
Thank you. What a beautiful room full of people, right? We do have a few minutes, and so we talked about asking, we would love to have a researcher better share their story of the research that they're working on or research that they would like to have done. We'd love to have a parent share their story a little bit more in more detail of what brings them here today. We have a room full of doulas, and that's really cool, doulas and midwives. And so if you have a story that you would like to share a little bit longer, we would love to hear from your profession and also your life experience a little bit more in detail, what brings you to this room with us today. Is there anyone that would like to be brave? We're going to be vulnerable today, people, so just put your hands up. You better buckle up because this is going to be a good day. Anyone? Do I have a researcher that will share some of what they're working on? Research is my jam, and it's my favorite meeting I attend.
Do I need a microphone?
Yes. Oh, that's me.
So again, I'm Kathy Meadows. I work with Intermountain Health, and we are currently doing a we call a prospective stillbirth study, where we are collecting surveys from moms about their loss, their knowledge about options available to perhaps identify risks or reasons for their loss. We're also collecting biospecimens to be stored for future research. If something is maybe found to be a commonality, we will have those samples, a large bank of samples, which is not currently available, to utilize to hopefully help decrease the stillbirth rate and help other women who hopefully do not have to go through that loss.
Amazing. Okay, who's going to be next? I'd love to get 5 people if we can get some people to share. Jane. Run, say run.
I'll start loud.
Okay.
I'm Jane Rollins. I gave birth to my son in May of 2020, right in the midst of COVID. Love that. It was a full-term stillbirth at 39 weeks to trisomy 13, genetic condition, not viable with life. After that, I got connected with Shared Parents of Utah, a bereavement organization that came to my delivery and provided mementos and photos and took hand molds and foot molds of my baby. And just, it was another lost mom who came and supported me, and that peer-to-peer support was invaluable for me. Several months later, I started volunteering with that organization as another peer-to-peer support. We offered not group therapy, support groups, and different events and workshops, activities, online Facebook groups, and eventually I also became what's called a hospital companion, where I went to births after loss, and now I provide the molds and the photos and the memorabilia, and I have the opportunity and honor to go sit in spaces with families of grief and able to be with them. And we provide, Shared Parents of Utah provides that to any family in the area who has losses. We love to be reached out to by hospitals, by midwives and doulas and home births and anything that will come and just serve that as a nonprofit, give that donation service, and connect with any parents who have that loss. That is a privilege and an honor that I've had to sit with families in that space and just connect with these families. And I love that work, and I love not being needed.
Thanks, Jane.
Absolutely, absolutely. sputah.org. More information there. Sorry to plug my own thing.
That's okay. We're going to have anyone that brought tabling or any information, will have it out. So, I mean, the purpose of today is to network and to learn from each other. So, do I have a brave doula in the room that will share a role that you do and why you're here today? Cool.
I don't know if I can stand. Sorry. I didn't think it would get me this hard, but it is. I attended the first stillbirth last July 2024. My very, very sweet client and friend was not alive at 42 weeks. We worked together really hard in labor, and it was tragic to see how it ended, and I believe it's still an open case, so I don't want to speak too much to the details, but I do know that shared parents played a very important role in their healing process. They were very touched by the roles and the companionship during that time, so thank you for what you do. I'm here today because although I'm a trained bereavement doula, I have no idea what I'm doing in that space. And rather than trying to fix or take away the pain, because I do know loss in regards to miscarriage that you don't want to be saved, but it's a fine line with the space that we hold. And so I'm here to learn more and grow my knowledge and expand my capacity a little bit. So thank you.
Thank you. Anyone else? Cool. Okay, everyone in the room, listen up for this resource because she's amazing.
I'm an executive director of Parents for Children. We are a nonprofit organization working with Latino and Hispanic women and parents. And we have a support group in Spanish for mothers and fathers that lost a baby or during the pregnancy. We are the only support group in Spanish here in Utah. We have sessions online and also in person. So when I heard the other moms here, I was thinking of moms that that we are working in the Latino community because the language and the culture is still a barrier for us, and we have a lot of Latino moms outside that they don't have any support. But I'm proud that we have a space for them. So if you know any moms, Latina or Hispanic that speak Spanish, please refer us. Our services are free.
What's it called again?
Parents for Children. I bring some flyers that I would.
You also do home visits, don't you? You do home visits as well?
Yeah, we do home visits.
Amazing resource. She's real cool. I think she was in front here. There's some.
I was writing things down. I just kind of wanted to share a little bit, like as a midwife. When I first started telling people that I was going to go to midwifery school, everybody thinks, they're like, what a beautiful job, like you're so lucky you get to hold babies, and what they don't know is that babies actually hate me because I bother them the second they're born until they're out of my care. And what they also don't understand is that while I get to sit there in some of the most beautiful moments in someone's life, I always also get to sit there and hold space in some of the hardest moments in people's lives when they hit grief that was unimaginable and that they never thought that they were going to have. And I got to experience that pretty early in my midwifery journey of holding space for somebody. And it really opened this door for me to want to continue my education so that I can continue to hold space for people. And we used Shared Parents of Utah for one of the doors that we had. And it was amazing. It provided great support in ways that I couldn't. But I always tell people when they're like, oh, your job is so beautiful and it's so amazing. And I'm like, it is. And it's really, really hard because I'm honored to be in both spaces with parents.
Very cool. Thank you. Anyone else?
Would you like anybody else to go?
I would love to ask Sega if he'll explain his research that he's doing. Is that okay, Sega? Well, like you have no choice because she's coming at you with the microphone, but like Sega is amazing, and I wish you could know of all the research that's happening, and so he's got some cool stuff going.
So I'm Sega Otarmo. I'm not a provider. I'm a researcher in maternal fetal medicine in stillbirth, and we have actually a stillbirth study that was mentioned earlier, similar to that. We're trying to enroll families, so both couples, mom and dad, and we want to collect placenta, and we were trying to investigate inherited and mutations that may be responsible for some of the unexplained stillbirth that we see pretty much a quarter to 50% of stillbirth are unexplained. So we're trying to close that gap and do that through whole genome sequencing. So we do need patient participation, and we need quality data, and we want to collect more samples to understand this.
Yeah, his research is amazing. So if you're interested, I mean, can you just give a brief description if you qualify for the study?
Yeah, so we're enrolling basically families who have not received a diagnosis. So excluding, trisomies would be excluded because it's pretty much explaining what happened there. So our study is called Familial and Genetic Determinants of Stillbirth. And I'd love for you to reach out to Sarah.
And Sarah's home number is?
and Stacey as well. So we'd love to
Probably everyone has my cell number at this point. Yeah, very, very cool research. Can I ask you how many research studies the University of Utah is doing surrounding this right now? Stillbirth.
So Sarah might know a little bit more about that.
Oh, good. Pass Sarah the microphone. She loves this.
So we've had probably 15 studies, 15 to 20 studies now. And so this one I'm talking about is specifically whole genome sequencing to try to identify mutations.
Very cool.
Can you do that sequencing without the placenta?
Yeah, that's a great question. And the reason why we look at the placenta is mainly stillbirth have underlying etiology traces back to the placenta. We would love to sequence the, from autopsy, we'd love to sequence the most of the placenta is actually the part of the baby. And it's easy for families to participate in the scenario. But yeah, it's a great question. We do both.
What week or gestation are we talking?
Yeah, for stillbirth, we're looking at 20 weeks and beyond. We're also trying to understand earlier miscarriages, which can be easily explained by older genetic testing. We're trying to do newer genetic testing to explain some of those that have no diagnosis.
And Sega, you have found pretty significant results with even like the environmental studies that you've done here in Utah, like mapping stillbirth clusters as well in different areas of the state.
Yeah, so we're starting from Utah to try to understand where there's a higher burden of stillbirth by geography. We're trying to understand the socioeconomic disparity aspect of the psychosocial impact of stillbirth, both quantified and intangible consequences, and that's ongoing. And I'd like to talk about that when we have results, and I'm happy to explain more if anybody's interested.
Very cool. Yeah, research. It's I love it. Okay, does anyone else want to share anything while we're here? Yeah. Or ask Sega more questions because he loves it.
So I'm Kathy, hospital chaplain. I want to share a story actually when I was a chaplain over at St. Mark's Hospital. And I was called to my first stillbirth experience. I met with the parents and they wanted to have their baby baptized. And so we set a time and I went into what's called the sacristy, which is the area that's right behind the chapel that has all the cabinets. And I felt at that moment like I was in a dream. I opened up one cabinet, I found this beautiful shell. I opened up another closet kind of cabinet and I found a beautiful stole to wear. Did not belong to me, but there it was. And I found some liturgy that a fellow chaplain had created, maybe the prior year. Beautiful bulletin, which I made copies of. And I met with the parents. What I didn't realize is they were going to also invite their 3 living children, baby siblings, to the ceremony. And they were young kids. But we all formed a circle together. And I held the baby. And I invited one of the siblings to take that beautiful shell and dip it into a bowl of water and pour that water over the baby's head. So it became a family event. And I can still close my eyes and see that circle and the sacred feeling that was in the air and the love of that family. And it really taught me the power of ritual.
Very cool. Love that. Anyone else? All right. Maybe we'll pass it back to you, Zen. Thank you for sharing. It's cool to get greater detail about who's in this room, so I appreciate it. Thanks.
So I feel really good now. I feel like I know a little bit more about, we all know a little bit more about who is in this living room today. And that's really how I like to think of it when I, in a large group of people at a conference or a talk or something like that. I like to just imagine that we are all in a living room, in community together, to learn from one another. And it's always helpful to know a little bit about some of the people who are, visiting the living room. So thank you so much to everybody for sharing a little bit about why you're here. And hopefully you'll have more opportunity throughout the day to share amongst each other and feel comfortable and hopefully glad to be here. So we're going to kind of do a little bit of a shift now to some facts and figures. Most of the day is focused on moving towards equitable bereavement care, but we're going to start, I'm going to start by orienting us a little bit to why stillbirth matters for health equity at all. And so this will be a little bit heavy on the facts and figures to kind of ground us all and orient us all. And I'm very happy to take any questions along the way. So please just it's a living room, interrupt me if you have any question or comment, or if anything I'm saying is unclear. Because sometimes when you talk about something a lot, you kind of get lost in it, and it's easy to forget how it might sound to other folks who maybe some of this is new to you. So in any case. Okay, got my script here so I don't forget anything. I do always like to start with definitions just to make sure we kind of know what we're talking about or using the same definition. Please feel free to come on down and sit, and welcome. So stillbirth is the death of a baby before or during birth. And the difference between stillbirth and newborn death is just survival status at birth. Did baby take a breath or not? Did baby show signs of life or not? The difference between stillbirth and miscarriage is gestational age at birth. And, there are different ways, different thresholds that are used to differentiate between stillbirth and newborn death. The World Health Organization uses a threshold of 28 completed gestational weeks, and that's mainly because data on stillbirths or births, fetal deaths before 28 weeks are pretty poor quality around the world. And so that 28-week threshold is partly used to help with comparability of data. But in the United States and in most high-income countries, the threshold is 20 completed gestational weeks. Also, most countries do differentiate between spontaneous fetal death, including stillbirth and miscarriage, and induced termination, which we call abortion here. So this is one of my favorite slides. To make the case for why stillbirth matters for health equity, we need to start with why stillbirth matters for public health generally. And the reason it matters is because there are a lot of stillbirths. This is a pie chart showing all global deaths to mothers and children under 5. I think it's from 2020. There are about 5 million deaths to mothers and children under 5. And stillbirths account for 1/4 of those deaths. That's very conservative as an estimate because here, using global data, we're counting stillbirths from 28 weeks on. If we included stillbirths from 20 weeks on, that red slice of the pie would be a lot bigger. I also want you to note, I'm doing advocacy as I do this presentation, my terminology. There are live-born newborns and there are stillborn newborns. And again, the parents and the providers in the room understand that survival status doesn't determine whether you're a newborn baby or not. Okay. Another point to note about stillbirths at the global level is that 40% of those stillbirths occur during labor and delivery. The picture looks really similar when we go to the national level. This is data from the United States from 2019. The pie would look basically the same if I use the latest global data, which is only from 2022. So here we see that if we're looking at the 42,000 infant deaths in the United States, half of them are stillbirths, about equally divided between those stillbirths above and below 28 weeks. 50% of infant deaths are stillbirths. And what's not typically understood is that there are twice as many stillbirths in the United States as there are deaths to children aged 1 to 14 from all causes combined. Accident, flu, whatever. So these two slides together at the global level and the national level hopefully make the case for why stillbirth matters for public health. So now we're going to go to, all right, there's a lot of stillbirths. Why does stillbirth matter for health equity? So the stillbirth rate is defined as the number of stillbirths per 1,000 total births, meaning live births plus stillbirths. And this is a map from the most recent global country-specific data. That global data is collected by the UN Interagency Group for Child Mortality Estimation, UNIGME. And this is a heat map with the darker colored countries having higher stillbirth rates than the lighter colored countries. You can see that the stillbirth rate in sub-Saharan Africa and South Asia is roughly 12 times higher than it is in parts of the world with higher income countries. That's a huge disparity. Also, within countries, there's great disparity as well. In Australia, the stillbirth rate in Aboriginal and Torres Strait Islander moms is 50% higher, 1.5 times higher than it is in white families. In Ireland, the stillbirth rate in poor counties is 3.5 times higher than it is in wealthy counties. And in the United States, the stillbirth rate in black families is double that in white families. And I think these statistics are important because the inequities are not only visible between regions of the world, but inside countries. We can see the inequities in our national stillbirth rates from this chart. This shows stillbirth rates in the United States from 2019, and again, the data are not that different in the subsequent 3 years, broken down by race and ethnicity. You can see that the stillbirth rates in black families, Native Hawaiian and other Pacific Islander families, and American Indian, Alaska Native families are much higher than in white families. And they are also much higher than the national stillbirth rate, which is 5.7 per 1,000 total births. And here we're talking about a stillbirth definition of 20 weeks and up. This figure is from a fairly old paper from 2011, about 15 years old. And unfortunately, I keep reusing this figure because the picture hasn't changed. This shows stillbirth rates from 1950 to 2005 And the orange triangles show stillbirth rates in Black families. The blue squares show stillbirth rates in white families. And you can see that back in 1950, the stillbirth rate in Black families was twice as high as in white families. And in 2005, the picture is the same. The stillbirth rate in Black families is double that in white families. And in fact, a couple of weeks ago, I actually crunched the latest numbers. I went back to the 1950 data. I found the vital stats data, and then I found the most recent data from 2022. And actually, the disparity has actually worsened. The ratio between Black and white stillbirths back in 1950 was about 1.9, and today it's 2.4. So this is kind of a busy slide, I'm sorry, and I'm going to walk you through it, but I think it's worth it, and it'll show up a little bit later in my presentation. The blue bars represent Black stillbirth rates, and the orange bars represent white stillbirth rates. And this is data from 10 years of births in New York City between 2009 and 2018. There were about 1 million births during that time period, and this is from research that I carried out. And I broke down the stillbirth rates in Black and white families by a whole bunch of different characteristics. There are two fetal characteristics, the stillbirth rate by gestational age there on the left, and by fetal sex. And then also I broke it down by 3 maternal characteristics. That's maternal age, maternal education, and also the borough. These are New York City data, so this was the borough of mom's residence. There are 5 boroughs in New York City. And the takeaway here is that you can see the blue bars are higher than the orange bars. So no matter how you slice the pie, Black stillbirth rates are higher than white stillbirth rates, every single subcategory. And in fact, for example, if we look at some of the Black and white stillbirth rates, we can see that the Black stillbirth rate is actually 3 times higher than the white stillbirth rate for male babies. It's about 3 times higher for older moms. And it's also about 3 times higher for moms who happen to live in Staten Island.
Sam, can I ask you a question?
You bet.
I understand this is a decade worth of data.
Yep.
Do you have any sense of like that if this is consistent with other decades?
So the question was, would we see this same picture if I took another 10-year period?
Is it getting worse historically?
Is it getting worse, or is it about the same? I mean, you know, as a scientist, I would say I need to check the data because I want to emphasize this is all 100% evidence-based, the data that I'm presenting to you. So, So it's interesting. I would expect that the disparities are worse, a little bit worse now than they were, say, if we were looking at the 1980s. And the reason I say that is simply because of the prior slide where I told you that I had crunched the numbers, and the national stillbirth rate ratio between Black and white families has increased. However, this is New York City data, and the New York City stillbirth rate is actually much higher than the national stillbirth rate. So this situation is a little bit different. Things do seem to be getting a little bit worse in terms of stillbirth rate disparities over the last number of decades, but yep. Yes?
When you say Black family versus white family, is it Black mother or birthing person? Does it matter in a racial family?
Great question. Yeah, so the question was how am I defining, or how are we defining a Black stillbirth rate? Is that is it a mother who is Black? What if dad is Black and mom is white? It's interracial or multiracial, etc. So thank you very much for that question. It's so important. The slides that I'm showing come from different data sources with different ways of defining what it means to be a Black stillborn baby versus a non-Black stillborn baby. Up here, the data that I used are from the census, and so race is self-identified in census data, and I excluded multi-race babies from this analysis. And the baby's race in stillbirth data in New York City are aligned with the mother's race. But that's a really great question. I can tell you that I did repeat my analyses using different ways of defining Black families. You see this is non-Hispanic Black families. I did repeat the analysis, and I'll be sharing some more results from that later, in all Black families, Hispanic and non-Hispanic, and I didn't find much difference. And in terms of the national data that I shared, again, those come from Vital Stats, and that's self-identified race. Thank you.
Zan, I know that data had been pulled in a while. Can you speak to that? Where you said you were the first one that did.
Oh, right, yeah. I will also say that I randomly was the first, I was the first person to publish on stillbirth rates in New York City. Can you believe it? I mean, it's just crazy. There's millions of stillbirths that occur in New York City, and nobody had pulled that data before me. And I'm just some random, person who was asking a question about stillbirth in New York City. So there's a lot of untapped information out there that we can use to answer questions of import. And I just thought it was crazy. They were like, great, you want to look at stillbirth? Fine. So that was, anyway. I also want to emphasize that the Black-white disparity in stillbirth rates persists into subsequent pregnancy. So this is, these two points are from different studies. But as many of us know, unfortunately, if you've had one stillbirth, your risk of having another stillbirth is higher, about double. Depends on the reason for the stillbirth and if you know that reason. But for Black moms, for African American moms, that risk is 3 times higher. I just also want to point out that, these are all facts and figures, and I believe, as I'm sure you all do, that they relate directly to, mental health outcomes in moms and families, and directly to the experience of moms and families as they go through subsequent pregnancies. So there's a lot of emotion and life behind these numbers. You bet.
Is there a relation between a miscarriage, like that qualification before 20 weeks, and that connection with stillbirth as well?
In terms of recurrence? So the question was, sorry, let me see if I can go back up. The question was kind of, is the picture the same for miscarriage? And again, I don't want to say the wrong thing. I'm sure there are many miscarriage experts in the room, and it's not a black and white, obviously, division. It's an somewhat of an arbitrary division between where kind of the gestational age threshold is set, and really miscarriages, stillborn babies, and newborn deaths are all on a continuum. With a merging of causes and so on. I'm sure that the picture is quite similar, certainly for late gestation miscarriages. I don't have the data, though, with me yet. So I also wanted to point out that just as I showed you that if you look just at the national stillbirth rate, it hides a lot of disparity within a country. Same thing with blanket designations of race, ethnicity. So this is a slide just showing the breakdown of Hispanic stillbirth rates in different Hispanic subgroups. This is also vital statistics. And you can see a range of stillbirth rates from going from Cuban American, the Cuban American stillbirth rate at 3.9 per thousand total births, to the stillbirth rate in babies of other and unknown Hispanic origin at 5.8. It might not look like such a difference, but actually the stillbirth rate in that lowest group there with unknown Hispanic origin is 50% higher than the stillbirth rate in Cuban Americans. It's a huge difference. And
do you think it's genetic or like socioeconomic or like everything?
Do I think it's genetic or socioeconomic? The difference is, no, I don't think it's genetic. I think that there are, I'm radically not an expert in Hispanic stillbirth research, but I would say that, there are maybe sociocultural factors that are different. Access to care is going to be different. Where you live, if you're Cuban American versus Mexican American, is going to be different. All kinds of things.
Sam, can you give an example of other and unknown Hispanic?
Yeah, other and unknown Yeah, what is inside the other and unknown Hispanic category? I meant, did I? Darn it. I took these data from the Vital Stats report, the most recent Vital Statistics report, which was published in 2024, and they do define that category, and I did not include it here. I think this will include, so when whoever is filling out the information for baby on race ethnicity is going to have an opportunity to check a box on race ethnicity, and then if they check Hispanic, they will also have the opportunity to designate what type of Hispanic group baby identifies with. If that box wasn't checked, it's going to go to other and unknown. So this probably partly has to do with crappy data. Whoever filled out that data on baby maybe didn't fill out that next level for baby's race ethnicity, or the parent may have chosen not to identify any further.
It is often a problem in the Hispanic community that the way, I don't know if you have experience with this, but like when people that you work with, that the way that classification is set up is highly problematic and people don't feel they identify with it.
So Brittany's saying that the options to check on that form often are problematic for Hispanic families who feel that they don't identify with any of the options to check, and so that would be another reason. Thank you. Yeah, thank you. Or they could come from multiple Hispanic subgroups, mom from one and dad from another. So this table comes also from those 1 million births in New York City over 10 years. And I just want to orient you that, each of the columns is a different race, ethnicity, Black, white, Hispanic, and so on. And you can see the stillbirth rate, that's stillbirths per thousand total births, along that first row. And then it's divided into whether whether mom was born in the United States or not. It's divided by nativity status. Was mom US born or not? And you can see that for every race ethnicity group, the stillbirth rate is higher if you were born in America than if you were not. You can also see that final row, that on the bottom there, is the ratio between the stillbirth rate if you were born in America or not. And you can see that disparity is greatest for Black families. So for Black families, the stillbirth rate, if you're Black and born in the US, is 15, almost 16 per thousand total births. Yep.
Can I ask a quick question?
You bet.
Did this take into account any of the related sort of compounding issues that we see more prevalently in the United states like gestational diabetes?
So this is just raw data, and in a few minutes I'll show you some results from some regression analyses. So yeah, these are just raw data that do not take any other factors into account. Another thing that is important to note when we think about stillbirth and health inequities is the disparity at a geographic level. And again, these are our 1 million births from New York City, and they're divided. So these are the bars, the orange columns are stillbirth rates in all 55 New York City neighborhoods. And they're organized into 5 groups according to the 5 New York City boroughs. And you can see that there's a huge range in stillbirth rates inside New York City, from 15.1 per 1,000 total births in one of those neighborhoods in Brooklyn to a low of 2.8 in one of the neighborhoods in Staten Island. And I went to take a look at what it means to have a stillbirth rate of 15 per 1,000. That stillbirth rate in one neighborhood in Brooklyn, in New York City, is higher than the stillbirth rates in Myanmar and Papua New Guinea. Now, those are countries in Asia that have a per capita income less than $3,000 a year. So the stillbirth rate in this neighborhood in Brooklyn is worse than a couple of countries with an annual average income of about $3,000. At the same time, that low stillbirth rate there is equivalent to the lowest stillbirth rate in the world. It's in Japan or Iceland. Here's Utah. And again, just as in New York City, we see that there's a big variation across the counties, geographic variation in stillbirth rates. So the darker orange areas are counties with higher stillbirth rates. And we can see that the areas with those higher stillbirth rates overlap substantially with the areas that are more heavily populated by American Indian, Alaska Native residents in the eastern half of Utah. And there's also an overlap with counties that have higher populations of Native Hawaiian and other Pacific Islander folks in the northwest corner of the state. This is data from the Department of Health. Thank you, Nikki, wherever you are. I don't know where you are. And this is something that I always like to emphasize. Stillbirth rates also vary by federal status. So welcome to the map of the 5 populated U.S. territories. Those are in green. There are 2 in the Caribbean, Puerto Rico and the U.S. Virgin Islands. And there are 3 in the Pacific, the Northern Mariana Islands, Guam, and American Samoa. The stillbirth rate in 3 of those territories is not available for a variety of reasons. But the stillbirth rate in Puerto Rico and Guam is woefully high. In fact, the stillbirth rate in Guam, a U.S. territory, at 13.3 per 1,000 total births is the same as in Morocco, with a per capita income of $4,000 a year. It's quite problematic, and it's quite difficult and challenging to study stillbirth in these U.S. territories because the numbers are very small, and that makes it hard to get sort of statistical significance. Here's another kind of gnarly slide. I'm going to walk you through it. There's race ethnicity variation also in causes of stillbirth. So these data are national vital statistics data, and they show the race ethnicity breakdowns from the 5 most commonly selected causes of stillbirth. I'm not going to do a lecture on the word cause. I have a lecture on the word cause, but we'll just go with it. You can see white stillbirths are shown by the light green bars, Native Hawaiian, other Pacific Islander by the purple, Black by the light blue, Asian stillbirth rates are the dark green, and American Indian, Alaska Native are the orange. So based on these data, If we wanted to reduce white stillbirth rates, of course we'd look at the unspecified cause, but we would next go to stillbirths from complications of the placenta, cord, and membranes, and we'd start to do research on how we can reduce stillbirths from that causal group. But to reduce black stillbirths, in addition to looking at that causal category, we'd also want to look at maternal complications of pregnancy and maternal conditions unrelated to pregnancy. Both of these causes are much less common in white stillbirths. To reduce American Indian stillbirths, we'd want to unpack that all other causes category. And to make headway on Native Hawaiian and other Pacific Islander stillbirths, we'd need to address those with an unknown cause, as well as diabetes-related causes. So the takeaway message here is that not only are stillbirths inequitably distributed across race, ethnicity, but causes can also vary by race, ethnicity. This is that same slide that I walked you through earlier, and I want to point out one other message, which is that risk patterns also vary by race, ethnicity. Remember that all black stillbirth rates are higher than white stillbirth rates, no matter how the pie is sliced, but take a look here, and we can see that the stillbirth rate for black births is highest in older mothers, but for white births, it's highest in teenaged mothers. So think about how that might relate to prevention activities. The stillbirth rate for black births is highest among boy babies, higher than girl babies, but for white babies, there isn't much of a difference. And for black births, the highest stillbirth rates are in Staten Island, but for white births, it's in the Bronx. Again, think about how that might relate to prevention activities. Okay, this is the toughest slide to explain. I'll just touch on it briefly. This is from my own research on associations. I was looking at possible associations between proxy measures of structural racism and stillbirth in those 1 million births in New York City. And one of the measures I used to capture structural racism is called the Index of Concentration at the Extremes. It's very unfortunately nicknamed ICE. Yeah. ICE models the relative privilege or disadvantage of a neighborhood. After I controlled for potential confounders, we found that black mothers living in New York City neighborhoods of privilege had a 54% higher risk of stillbirth than black mothers living in neighborhoods of disadvantage. There was no evidence of associations in white moms. So we hypothesized that this could have to do with reproductive health care that is worse for black women in neighborhoods of privilege, perhaps due to provider bias or racism within the health system, or possibly black women experiencing greater or more constant exposure to stress in neighborhoods of privilege, for instance, due to microaggressions or interpersonal racism. Yes?
Sandy, you think that the statistic would carry over into maternal mortality statistics as well?
Do I think I would see this in maternal mortality? Again, I don't want to opine on an area that I don't do research in.
Sorry, Van.
But I will say that this was not a finding in alignment with much of the literature. However, much of the literature looks at, well, there's almost no literature on structural racism and stillbirth, but the little that there is lumps all babies together and doesn't look separately in black and white births. So I think bear with me for a little bit longer. I know this is an awful lot, and I just want to share some of the next few slides with you, and then I'll be done with talking about this. But the variations in the degree and type of stillbirth risk across race, ethnicity, and other characteristics means that research and prevention have to be tailored to those groups, or at least take that into account. But research typically does not do that. This chart, also from my own research, summarizes analytical approaches that were used in 100 reports of black-white disparities in stillbirth rates. And that's shown by the blue bars. The orange bars show authors' explanations for the disparities that they found in their stillbirth data. By far, the most common analytical approaches that were used to explore racial disparity in stillbirth rates looked at maternal and fetal characteristics. For example, gestational age or birth weight, maternal BMI, maternal medical conditions. Almost none of those reports used any structural or health system factors to explore those disparities. The research is almost non-existent. And also, studies of racial disparity in stillbirth rates rarely examine some of the highest risk groups. So here we remember that the stillbirth rate in Native Americans and Alaska Natives is quite high. And yet, the review that I did of racial disparity in stillbirth rates found that only 16% of studies even looked at Native American stillbirth rates. So in 2016, the Lancet Medical Journal published a really important series of papers called the Ending Preventable Stillbirth series. And that series of articles included a call to action. It's here on the screen. It included a call for countries to set and then to try to meet stillbirth equity targets. The International Stillbirth Alliance, which I'm a past chair of, we were worried that people would forget about this call to action, and so we created a scorecard to track progress against that call to action. And here on the screen, with a lot of writing, is the 2019 version of the scorecard. And basically, red is bad, orange is so-so, and green is great. On the left are the 20 indicators that we look at as we assess progress towards the call to action. And on the right are columns for the different global regions, including Asia, Africa, and Latin America. So as I said, red is bad, green is good, and gray means there's no data. You can see that most countries had not only not achieved a global stillbirth target, which is 12 per thousand, but they had not even set a target. And most importantly, when we look at the call to set and meet a stillbirth equity target, there's no data available at all to measure progress. We don't even know where we're at. So this is my second to last slide, and I think that, this basic pair of pie charts kind of sums up the crux of the sort of stillbirth inequity crisis. So on the left are live births, and on the right are stillbirths. This is national data from 2022, so hot off the press. It's the most recent data available. And you can see that while black births constitute 14% of all live births, they make up 26% of all stillbirths. Essentially, there are far more black stillbirths than would be expected in a situation of full health equity, meaning if black and white stillbirths occurred in proportion to black and white live births in the population. So I adapted this figure from, as you can see, the citation down there. And I would say, despite the persistence of a doubled risk of stillbirth in black as compared to white births, the research on why this is so is very sparse, and it's focused primarily on individual level factors related to the mother and the baby. There's very little research on stillbirth inequities in relation to structural factors such as structural racism. As we know, structural racism is an interdependent and self-perpetuating complex of institutional practices, laws, and policies that oppresses members of a group because of their membership in that group. Structural racism has been associated with many adverse health outcomes, ranging from infant mortality and preterm birth to birth weight and severe maternal morbidity. And as I've shown, it's also associated with stillbirth. Research to reduce inequities in stillbirth rates cannot ignore these major structural features of our nation. So I hope that I have adequately conveyed why stillbirth matters for global public health, for national public health, and for health equity. I would say that achieving health equity requires equity in stillbirth prevention and research, and it also requires equity in stillbirth care. And so with that, I'm going to hand it over to Stacey unless there are other questions. Thank you very much for your attention.
So I am speaking today on the impact of parents and the need for equitable bereavement care. And I'm going to talk about an overview of the emotional burden on families following a baby's death, but also disparities that challenge equitable bereavement care. 2 weeks before Christmas in 2006, my life changed in a way that would completely alter the trajectory of my future. I tell my story from a place of healing, but also I want to portray the rawness and intense trauma that accompanies pregnancy and infant loss. It is in this brokenness, in this isolation, in this vulnerability that we can best understand bereavement needs and support. A very wise friend of mine, who happens to be in our audience today, taught me an important lesson about continuum of care. She said, as families travel their journey of grief, they are forced to walk through many doors. Their story, their support systems, their care, their tragedy goes with them. While in the healthcare system, we as bereaved parents need to be accompanied to each door. We enter and hand it off to someone on the other side to continue our journey through the next door. Our history and our stories need to go with us as patients. The idea of doors has stuck with me, and because I'm a former English teacher and I love symbolism, I want to use that idea here today. My son Benjamin was stillborn on December 12, 2006, when I was 39 weeks along in my pregnancy. The prior day, due to lack of movement, I entered a hospital door for a non-stress test and met heartbreak just beyond its threshold. The hospital door was not easy for us to get to because I lived in Ephraim, Utah, and I had to drive 90 minutes one way for my appointments. I lived in a medical desert for OB care. These deserts are one of the real barriers that families in our country face to receive equitable health care. In fact, medical deserts are a risk factor for increased stillbirth. When I returned home after Benjamin died, I returned home to a mental health desert as well. As I walked through the hospital door that day, my life changed forever. Since then, my knowledge of equitable bereavement care has increased, and I can see that although I had a distance to travel to the hospital, I walked in those doors as a straight, white, upper middle class, married woman. The door was wide open for me, and I want to acknowledge and recognize my privilege in that moment. For some, hospital doors are barriers to adequate health care, systematic and generational trauma, distrust in the medical system, or not accessibility to financial constraints. I have queer friends who did not have access to their baby's records or health care decisions. Hospital doors may be challenging for some to open and feel closed or barricaded for others. The next door that I entered was labor and delivery. I remember the exact words as a sonographer read the ultrasound that afternoon. As you can see, there is no heartbeat. I remember my husband's face. I remember that my nurse was pregnant. I remember that my contractions started immediately. After 18 years, my memory still clings to phrases, random faces, the terror that I felt, but I don't remember switching rooms or ever being put in a hospital gown or being told a plan for what we were going to do. We were put in a labor and delivery room away from the nursery in the corner, and I believe that I went into shock immediately. and that my contractions began as a result. I feel that shock protects us from the reality of trauma, and I think that it wrapped around me like a warm blanket of protection. I do remember my husband's face, and I remember the pain that flashed in his eyes over and over and over again. He called our parents. He called my sister to pick up the boys, to keep them safe. He called a mortuary. He called the city offices for a burial plot. He could not stop crying. When a mom is delivering a stillborn baby, the room is hauntingly quiet. People speak in hushed voices and whispers. There is no heart monitor that hums and shifts with contractions and movement, just silence. Silence and immense sadness. My hospital room door softly opened over and over again as I labored for the next 31 hours. As my husband and I navigated the tender journey of saying hello and goodbye to our son, we did the best we could do with the information we were given in our emotional state. I spent 2 hours with Benjamin before he was taken to the morgue. We never got him dressed. We never wrapped him in a blanket, put a diaper on him, or held him in our arms. We declined an autopsy due to financial constraints and incorrect information. As we all know in this room, and we should say this together, autopsies are free in the state of Utah. And that they do find answers. When we were asked about photos, I told the nurse no. Why would we ever want to remember that day? We were never asked again. That decision is one of the biggest regrets of my life. My husband and I snapped one photo of our hands holding Benjamin's hand. The photo is the only thing that I would leave the hospital with. And today I'm a bereavement photographer. I remember the nurse took Benjamin away before we brought in our boys. They were excited to meet the new baby, and it was our job as parents to explain what had happened. They would not meet Benjamin that day at the hospital, but briefly at the mortuary before the funeral. I remember the sobs, knowing that part of them would never be the same. Death had touched them, it had beaten them in a way that no child should experience. I knew that moment that our family photo would never be complete. In the coming months, they would sleep on my bedroom floor at night on little beds that they made. I would lay awake and watch them breathe, and I would get up at night to make sure that they were okay. They would struggle emotionally, socially, and even physically. I wonder now what bereavement care would have looked like for them. We shelter our children from the harm, the fear, the reality of death, and when it comes, it can be brutal on children. Life and death, before and after, wholeness and brokenness, happiness and sadness. Before Benjamin's funeral, I watched my boys stuff their favorite toys and art and messages into Benjamin's tiny casket for him to keep forever. When the beloved teddy bear went in, it almost broke me. This was their way of grieving. We had the funeral before the snowstorm hit. It was almost Christmas, and the world was bustling to finish up before the holiday. Benjamin's Christmas stocking was hanging on the mantle, and his presents were wrapped under our tree. My husband carried Benjamin's casket while the boys followed behind me. It was cold. I wrapped him in a warm blanket and put a white hat on his head. I would later put a solar light at his grave as a nightlight. I could see the men who would fill his grave with dirt in the corner of the cemetery. Their truck was running because it was cold. Everyone hurried from the cemetery due to the weather. They went back to our house to eat. The men were waiting. How does one just drive away from a baby's grave? We didn't know how to do that part. How were parents supposed to do that part? Do we just drive away? I smiled in the photo next to his grave and the little white casket. It would be the last photo my boys would be all together. I smiled. Is that what we're supposed to do? The shock and the numbness were so intense. I remember watching the story like it was a movie playing out in front of me. I felt that a piece of myself crawled into the casket with him that day to keep him warm, to keep him safe. I didn't know. When I walked in the front door of my home after the funeral, my milk came in. In reality, I feel that it was this door, my own home, that broke me. I sat on the bathroom floor holding my chest while relatives ate ham and funeral potatoes in my kitchen. It all seems so strange now, even 18 years later. It is one of the most important events in my life that I see in glimpses because trauma was so intense. The smile in the photos will always haunt me because I didn't know how to be me anymore. Parts of my identity, my existence, my purpose, my heart were falling off of me. And I walked on, leaving a trail of loneliness and isolation and womanhood and peace and safety in my wake. When I returned to Provo for my 6-week postpartum check from delivery, I was greeted by an enthusiastic receptionist who gave me a pile of formula coupons and asked if she could see my baby. My doctor never did touch me during my postpartum exam or provide additional follow-up, in spite of my high blood pressure, continued bleeding, an infection in my chest lining, and physical and emotional exhaustion. I would never hear from his office again. It would be 8 years before I would reach out to a peer support program. The pressure of Benjamin's death eventually broke my children wide open, and we began to drive to Primary Children's Hospital for therapy. It was 2 hours from my home, taking an entire day and more missed school to battle the extreme anxiety and depression that settled on my boys. Our family was rebuilding systems that we once thought were absolute. The medical system, our family system, religious systems, the world in general. We had to rebuild them all. We were running through doors of grief and rebuilding so quickly and violently that it would be years before we opened an important door to healing. The reality now is my biological sons are more likely to experience a stillbirth because of our genetic history. They are aware of this risk, and the threat of stillbirth runs like lightning through our memories and in our blood. My grandma had 2 stillbirths. I remember that she whispered about her babies when she told their stories. Did anyone speak with my grandmother when her babies died? She had home births. What care did she receive? Because 60 years later, she still couldn't speak about her sons other than in hushed tones. Her first baby was named Lawrence Andrew Nielsen after my grandpa. The doctor who delivered the little baby said that he saw the baby shudder. This was a sign of life that everyone needed, and my grandma was comforted to know that he would be hers in the next life, in the hereafter, she would say. And she would see him again. She had a blurry picture of him taken through the house window and a photo of his casket. The next baby that she delivered died before birth. There was no life when he entered this world, no breath, no shudder, no heartbeat. I remember her explaining that she didn't know what would happen to this baby because he didn't take a breath. She had been taught that breath determined existence. The sweet little boy was never named. It was just a fact to my grandma. That's just what they would say. Yet I never remember her talking about one baby without mentioning the other. I wish I would have asked her more. I was one of the few grandchildren that knew the story. I didn't know then that I would be walking down a similar road in my own future. I think of my grandma a lot and the loneliness that she felt so many years ago when she walked through that door of grief. I remember when she died that she felt that she would be greeted by her sons. She was already gone when Benjamin died, but I'd like to think that she found me in the darkness and sent me some light and love. Trauma travels through space and time, through generations. It forms who we become and develops struggles that challenge us to our core. My grandmother, my sons, and now my daughters. I can't look at them. We have 3 generations who experience deep grief and the need for intense bereavement care on countless levels. The continuum of care after the doctor left my grandma's home, after my sons began to sleep on my bedroom floor, after I entered a world of isolation and PTSD, and now my daughters, who are the beautiful Black women who stand with me today. They are twice as likely to experience stillbirth as mothers. Not because of genetics, they are adopted, but because of the color of their skin. The color of their skin. Doors that are open to me do not open to them. Bias, racism, and distrust have followed them into adulthood. Even now, I watch them struggle to open doors that only moments earlier I walked through. I have privilege that they will never, ever know. I tell our stories because providers and clinicians need to understand what happens not only in hospital systems, but when we walk back out those doors into our homes. Is there someone to walk with us? Is there someone on the other side of those doors? Or do we enter a world of isolation and deep grief alone? What happens to us next? What doors are held open for us for our next experiences? And what doors must we bang on and beg for keys to enter and heal? I work with the most amazing clinicians and providers. The nurses who took care of me at the hospital years ago were sincere, loving, and compassionate. But I needed to be shown how to parent my baby. The system needed more. I needed someone like myself, a bereaved parent, to sit with me and show me that I would live through the darkness and model the care that I needed to give my son, to tell me how to care for his little body. I needed follow-up care and family support and financial help and so many things. They were simply not available in my location and situation, or I didn't know how to access them. When a baby dies, parents need resources and continuum of care. So much happens when we walk through the front doors of our homes. But just imagine those families who do not have a home, or a partner, or a support system, or a community. These are gaps that as providers we must fill. As humans, we must fill. As we look around this room this day, I want you to look at your support groups and clinical schedules. How many people of color do we see? Yet we know that these populations, Zan just told us, carry the highest burden and heaviest systematic injustices. This is where we begin. When we walk out of the door of this building, we leave as different people, as more complete caregivers, as better educated citizens, as humans who not only see the gaps and injustices, but as advocates who step forward and lean in to fill those spaces. I appreciate your time and opportunity to share my story and the life and legacy of my sweet Benjamin. Families whose babies die have a place in this work. We become very, very intentional. They would say helicopter type parents. We raise empathetic children. We heal and we thrive. We fight as advocates. We lead and participate in research. And we learn to sit in the quiet and guide other families into their journey of grief and rebuilding. We wait behind and in the thresholds of open doors and open arms with those who travel similar roads. Thank you.
I am very honored to introduce our first keynote speaker. Dr. Ferguson is a distinguished physician leader, health equity advocate, and community organizer who has long been dedicated to improving healthcare outcomes and advancing inclusivity in medicine. He's board certified in family medicine from the University of Utah and has practiced emergency medicine in critical access facilities throughout the country. He also has an MBA from the Eccles School of Business. Dr. Ferguson served in the U.S. Army as a battalion and brigade surgeon for 7 years in Operations Iraqi and Enduring Freedom. And he has said that one of the most impactful times of his life as a physician was in the care of his soldiers and their families abroad. Dr. Ferguson has consistently championed initiatives that address systemic healthcare disparities. In 2021, he established the Black Physicians of Utah to improve healthcare outcomes for Black and underrepresented Utahns by increasing the number of Black physicians in the state and through multiple health education initiatives. Under his leadership, BPOU has launched cornerstone initiatives such as the Medicine Immersion Day, which connects Black physicians and medical trainees with young Black and marginalized students to inspire future healthcare professionals. He also spearheads the BPOU Clinical Research Internship, which offers Black undergraduates and rising freshmen immersive opportunities to engage in clinical research. He most recently helped to launch BPOU's Mental Health Advocacy Branch, which focuses on informing and addressing the mental health needs of Black Utahns. Dr. Ferguson also works as the Chief Medical Officer for Health Choice Utah, where he oversees clinical strategy and operations for the organization's Medicaid health plan and has been instrumental in developing programs to improve access to care for historically marginalized populations. And he's the interim CMO for University of Utah Health Plans. Dr. Ferguson is a recognized leader in combating ageism in healthcare and in promoting health equity across diverse patient populations. He's led key health education events addressing chronic conditions, including obesity, cancer, and heart disease. And in his spare time, which I can't believe he's got any, he's also completed over 40 triathlons. So please join me in welcoming him to our symposium.
All right, everybody can hear me okay? Or do I need to speak into this? This sounds okay? I like to move around a little bit. All right, well, good morning. Yes, it is still morning. Thank you for that lovely introduction. I'll have to give you my shorter bio next time. I was like, oh, she's got the long one. And as a slight correction, just because there's been a change, I am now the Associate CMO for University of Utah Health Plans. No longer interim, I now have a boss. So I'm no longer free reigning it. So one thing that, when I was asked to do this keynote today or a talk, I said, so do you kind of want me to just give personal experiences? Do you want me as someone that's worked in the ER and has done quite a bit of humanitarian care, some of the vestiges left over from my time as active duty in the Army as a physician, I have actively seen, and unfortunate women that, if you think there are disparities in healthcare now in our US, just think about pregnant refugee women that are getting zero prenatal care until possibly a doctor like me stumbles into their tent, checks their blood pressure, and does an ultrasound. And I have to say, more than 50% of the time, I don't have good information once I perform it. I'm actually about to go on a medical mission to Amman, Jordan, to take care of Syrian refugees in about 3 weeks. So look for photos of that on our BPOU Instagram. But anyhow, this topic really struck me because it's not discussed enough. And of course that led to me having to do a little bit more research myself because I don't know if people here, did anyone go to our Aftershock event we had 3 years ago? Okay, so some people might remember me when I had our little panel, but that was a fairly moving film. And that sort of, to me, it brought it a little bit more into mainstream through film, through art, because I think it premiered at Sundance the year before. And that really motivated me to say, wow, I knew that there were always disparities for Black women when it came to maternal health outcomes, but having been asked to speak today, I was really struck by, wow, it doesn't stop with just delivery or complication with the mother. Quite a bit continues in utero that will lead to a stillbirth. So I'm going to kind of take you a little bit through history here on what I feel are the causes, our foundations in our nation, in our system, in our institution that leads to continued problems with stillbirth. But also I'm going to lend on a little bit of a happier note because this can be a troubling and a challenging topic to discuss. So, the how and why of health inequities and stillbirth prevention in America. Bit of a mouthful there, but so much can be connected to our foundations on some of the how race is recognized in our nation, and also where you live. So, why this matters now, and please forgive me if I'm doing a little bit of repetition from the lecture that was done before, but I felt like, having it at least 2 or 3 times doesn't hurt. So, in 2023, U.S. fetal mortality rate was 5.5 per 1,000, and persistently higher for Black, American Indian, and Alaskan Native families, and a gap that's largely unchanged for decades. A gap that's often largely unchanged for decades are doctors that look like me, which is kind of why there's this impetus and reason for BPOU, because for decades, since pretty much 1971, the percentage of Black male physicians have not increased in our nation, even though there's tons of programs, and my programs and what I'm doing is not so much very unique to Utah, but not across the nation, but yet we still can't seem to budge the needle. Same applies here when it comes to fetal mortality rates. So the inequity, Black pregnancy, and mind you, most of my slides I will be referring as Black, marginalized groups, or American Indian, just because I think that's the racial classification that the CDC uses in Alaskan Native. You have to understand, I represent a Black nonprofit organization. Most of my experiences will be with, and as a Black community leader, I'm hearing the voices and stories and history of Black women that have experience with maternal care. So just as a little caveat there, shouldn't be a surprise. But the inequity, twice the risk of stillbirth versus white, even after you adjust for socioeconomic, which I will go into later when we start going through a little bit of social determinants of health. But this points more to the structural and clinical drivers that I'm gonna go into here in a bit. So here's a quote that I often think of when I'm doing any lecture that addresses health inequities, and that is, the transform healthcare, we must acknowledge that trauma of systemic racism, which I will discuss at length here today, the trauma of systemic racism together to solve it. And Peggy McGuire, if you can read some of her stuff, it's great. And then also, this is something we see frequently during Black History Month, January. Sometimes this quote is taken out of context, but of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And a lot of this, you have to understand, the perspective that Dr. Martin Luther King was coming from at the time, and that's in the Jim Crow era, the Jim Crow South. In Jim Crow South, if you wanted to codify and have a perfect example of codification of racism, saying, because pretty much if you make it a law, then it's not illegal, right? So if you make racism legal, then no one's doing anything wrong, and then there's no prosecution, and you just keep widening that gap. This applied a lot to healthcare access, as I will soon go into, although briefly. That is one of the vestiges of systemic institutional racism that is still very, I wouldn't say, I don't like to use the term prevalent because we're aware of it, we're trying to stem it, but it's still very much present, stronger in some areas of our nation than others. So, the origins of health inequity in America. I think before we can get to America, we have to also go back to race. Race as a social construct, right? Because all of us, besides our phenotypic expression right now, we are all the same, bleeding the same. We all, well, many of us, if you live long enough, will develop hypertension possibly, have impairment with your organs. We are very much the same, but it didn't start until we had the father of taxonomy, Carl Linnaeus. All right, so this is a Swedish biologist. And he didn't feel he was doing any harm at that time, but he was taxonomy. He went through and said, this is the genus and species for many of type of animal and organism on our planet. He was starting to define that. However, he defined us as Homo sapiens. And then from that being designated, I then went from, that was then taken by a French philosopher. And he then took that about 14 years later to coin the term race. All right, so I think his name was George Louis Leclerc. And he was the first time to use race as a scientific term. Okay, so just like with codification of racism that I'll go into later, a racist law, which we unfortunately, it's coming up in our modern media today, but the codification, so when we started to use the term race, which started us as just a biological term of how are we going to classify people, it went from race, from the French philosopher, and then eventually it went full steam with Blumenbach, and this is a German physiologist, and he expanded the idea on the natural variety of mankind, proposing that there are 5 different races. And then he pulled upon his Linnaeus, and you had to have descriptors if you're going to have further taxonomification of humans. So it went further into describing people, and then once you start putting this down and calling it science, it then is going to make it where? Into a textbook. And someone's going to say, and then so people that are leading institutions are going to say, well, you know why this race acts this way. It is part of their DNA. This is part of how they have been classified. See, it's been studied. Dr. Blumenbach wrote it down. Therefore, it is fact. So we get descriptions such as Native Americans, obstinate, married, free, regulated by customs, Afrikaners, relaxed, crafty, negligent, governed by caprice. This is all how this was translated in the turn of the, or should I say mid to late 18th century, which also there was an unfortunate trade that was occurring during the transatlantic at that time, which made its ways to the Americas. But what I really want to emphasize here is these foundational principles on what is race, what it is to be human, made it into our leading institutions, particularly our medical textbooks, when it came to describing how one race will act upon another. It's the othering. This is the beginning of othering one race from another. And the majority of this text was written by Caucasian or those of white descent, or pretty much those that were not distinguished as being of color. It is seen as the original race, therefore the most beautiful, often associated with higher intelligence. So you have this as justification for often when someone is enslaved, particularly in our history here, saying, well, this is appropriate role for them. They are different than us, othering, and it's also another term for that is dehumanizing when it came to early foundation of racism in the US. So as we go a little bit further, what are the forms of racism? Because sometimes we hear systemic a lot, but we didn't realize that there's pretty much, I'll just say 5 different types that make the one. And I will spend more time on interpersonal, structural, and institutional. Internalized, that sometimes is taught by someone. That's what you see often demonstrated widely in media. It's the ugly stuff that you see from period films in the Jim Crow South, or possibly on media today at a possible protest or rally if someone's yelling slurs. But for the most part, I will focus more, because we don't really generally see that in our healthcare place. You may hear somebody say something under their breath when a woman of color who is coming from, possibly unhoused and is pregnant and seeking care, and may have an odor of, when they come into the room because they're unable to maintain their hygiene, and then comments will be made by the staff. And if they say something such as those people, that's when we get into, that's almost a form of internalized, but that's more interpersonal because it's directed particularly at that individual, but also she's not stopping there. That means if she's feeling this way about that particular individual, it can apply to other individuals that look like her. So, but I'm going to make sure that we have healthcare examples. So, definition, so internalized racism, just as background. So that involves accepting the negative societal beliefs about one's racial group that affects one's self-worth or behavior. So patients may delay or avoid care. So this is where we start to, when you don't have trust in the healthcare system, this is where that mistrust begins. And this is why we have, how many people here have done cultural sensitivity training? Although sometimes people are like, oh, I'm just gonna click through the slides. Let me go really fast because I want to get this done so my supervisor doesn't think I did. There's a reason why it's done, and this is part of the reason why. Interpersonal racism. So this you may see amongst peers, colleagues that you work with, family members. So the definition here, and it's slightly different, this involves discriminatory behavior or language between individuals that affects relationships or an interaction. So that's, sometimes we can see this as, I experience this more so as microaggressions. Someone will say, well, you did a really good keynote the other day. You speak really well for right? Or I wasn't expecting you to do. That's a form of interpersonal racism, but we'll use a more PC term and call it a microaggression, because that person will say, well, I have nothing against black people or people that, I just like good speakers. That's all I was saying. Impact on healthcare quality. So racist behaviors like this in healthcare can reduce patient dignity, it hinders communication, and can cause treatment errors or non-compliance. Once again, breaking down trust. If people feel that you do not trust them, they do not feel like they are heard or listened to, this will continue, especially, so the biggest thing here is if you see this happening, and this is why it perpetuates, if people will see this happening and they don't do anything to correct it. And that's often what part of my call to action is. We have to share when we know something is wrong. We don't have to embarrass the person that's doing it. There's an appropriate way to give constructive feedback to say, do you realize the impact of this? We may lose this member from our practice. This person may have a poor outcome with their child because of how we made them feel. We blamed them for their possible poor outcomes that are going on with their pregnancy, right? So, and then addressing this, once again, comes down to cultural competency. This is actually a large part, I wouldn't say it's probably about 10% of what we do when it comes to talking to allied healthcare providers, allies, to try and address cultural competence. Because no one wakes up and says, I want to be racist today to people. But there are actions that slowly occur, especially if not corrected, these will continue. So BPOU, and along with several of my black physicians, we go around the state actually trying to give lectures to medical schools, faculty, departments, but more so those that are at chief and divisions, so that they understand, please try to stem this in your own department so it can stop. We can't be everywhere. We don't assume also that this falls onto that one person of color to correct all this and teach us how to not be racist or anti-racist in our department, right? So if you have that one Native American doc or nurse or Latinx nurse or doc or PA, it doesn't fall to them to correct your behavior. So I will sometimes switch between obstetric racial bias and racism. I wanted to work in a case here because to kind of keep us grounded, but it's still real life, it's reality today on how maternal health outcomes are impacted based on racial bias or racism. So this first case, many people will probably pick up on it here in a little bit. I'll probably ask you before I get to the photo. So, not listened to, someone where they feel their concerns were dismissed. So, after an emergency C-section, a woman developed shortness of breath and specifically requested a CT scan. So they were knowledgeable about the healthcare system and what possible complication. So this was a fairly well-educated patient that knew their body and knew something was wrong shortly after C-section. And asked for heparin due to her clot history. So she was already concerned about what? PE, right? Staff initially attributed her concerns to pain medication and ordered a leg ultrasound instead, even though they had a clot history. CT was obtained only after her insistence. Once again, self-advocacy, which we at BPOU take very seriously, wanting to convey to our patients, leading to finding multiple pulmonary emboli, anticoagulation started. Who is this person that? Very good. All right. Okay, so that is someone has the means, knew their body, knew their condition, knew their risk factors, and still was not being listened to. Imagine if it's someone without those means. So, institutional racism. This is where we can all start to have some impact or effect. It's embedded in organizational policies that lead to often unequal outcomes for racial groups. Hospitals in predominantly black neighborhoods often have less funding, outdated equipment, and staffing shortages. You can see this more prominent where there is a larger minority population in, say, a certain city. So you're thinking, you're Memphis, you're Atlanta, you're Detroit, Chicago. Cook County is an example. I think it's, is it Greeny? I'm trying to remember, it's something with a G in Atlanta. They're always threatening to close it down, but it's in a predominantly black neighborhood, and it has limited funding and often able to They often sometimes have to send someone out to an Emory or another institution that has more means. So why do they not have as much means? It's because it's based on the tax base of that everyone's lives in there that helps towards the hospital. Is it a nonprofit that people don't donate much to? Is it about they don't really have their representative doesn't lobby to actually get much funding for them? Did they not get someone to advocate for Medicaid expansion in their area, but they did on the other side of town? Mind you, it works by state. But I think you're kind of getting my point. This is when you're at a policy level that can impact an institution. So often you have unequal resources that limit access to quality health care that can lead to poor outcomes. And then we go from institution to structural. So structural, this is where we have societal systems and policies. This is where I talk about Jim Crow, what's it called? The Flexner report that came about in the turn of the 20th century that led to really significant reduction of black physicians in our nation because they closed down 4 out of the 7 medical schools, black medical schools at the time, because the hallways weren't wide enough, or they didn't feel they had sufficient surgical equipment in that particular med school for training purposes. So, redlining, that's what I kind of have here with this description. Segregated neighborhoods, limited access to quality health care. I'm sure people have seen possible movies, news stories where you pretty much, black folks in that marginalized group didn't get a choice and they just put a highway right through the neighborhood. And so there's not even a crosswalk to get to the other side. And this isn't necessarily just to the US as well. Right, this has been done in other countries where you have folks that, they shift to the other side of the river, they're on the hill now, the more flood-prone area, people can't afford to get out of, they stay there, their hospitals aren't as well funded, they don't get the best healthcare access, thus their life expectancy is lower. But some of that is a result of structural racism, and particularly because there's system or policies that have been put forth to lead to less resources for that one neighborhood. So communities affected often lead nearby hospitals, specialists, and impacting care. And also that will lead to people like myself, we often applaud many black docs that want to move back to an area, say they came from, they were able to make it out of this, where they had social determinants of health working against them to become a physician. And if they go back, but often they will not have many doctors in that neighborhood. So someone has to take away from work time to go on the other side of the river, other side of the freeway, other side of town, just to try and get the same access to care that the people already on that other side of town had. So, or racial bias in medicine. We have another example. So, leading cause of death for maternal outcomes. So, not particularly the C-section, but postpartum hemorrhage. So, see if anyone can identify this case. So, following a routine C-section, a woman's husband repeatedly reported bloodstained urine in worsening condition. She was not taken back to the OR for roughly 10 to 12 hours after this. Surgeons later found massive internal bleeding. The patient died, prompting a federal probe and national scrutiny of how black mothers are treated. Does anyone know who this was? Who?
Kara Johnson.
Very good. So, once again, someone with means had a C-section. Doctors should know that we're taking care of her. The nurses should know, who was probably at the bedside with her, especially post-op, and the husband was advocating. Mind you, I have another example where the same thing was occurring for a close friend of mine I went to college with. She was having the same complications, but it wasn't until her white husband spoke up that actually they started to intervene, got a blood count. Oh my God, your hemoglobin's 5. She's having postpartum hemorrhage. Let's take her back. But she was saying, I feel weak. Why is my pulse high? What's wrong? This doesn't feel right. I don't feel right. And on top of that, the doctor was changing. It wasn't the person she had most of her pregnancy with. It was someone that was covering for that practice. So she went from having a black female for most of her pregnancy, but of course, babies don't tend to come on as planned. So she ended up delivering with a partner, and that partner dismissed a lot of concern, an Asian male. So, structural racism in medicine. It leads to a historic lack of respect for black and brown bodies. Deeply rooted belief system about black health as less important for centuries, and an unconscious, this is the key, unconscious consideration of pain tolerance. That's that othering, right? That goes all the way back to the 1700s. So, and then this all, if you remember my little diagram there, it then all feeds into systemic, which is you have widespread racial bias that's present in institutions, leading to persistent disparities, and that will impact healthcare outcomes. So that leads to that higher maternal mortality rates among black women, also Alaskan Native and American Indian women, and the institutional effects will lead to, it influences medical education, research priorities, healthcare access. But the other thing that I really want everyone to take away is the only way that we can really begin to try to address this is a holistic approach that includes reforming our curriculum. But we might get fined for that if we bring up race and its impact on healthcare. Diversifying workforce, BPOU, and prioritizing equity in policy. Hopefully, people on the Hill will continue to take health equity seriously in Utah, such as Senator Escamilla, right? We have our doulas now. That is now being covered. For a while, it was just out of pocket, and if you had the money to do so. That's something that I really pushed and advocated for the last 3 years. Yep, come on. What's going on here? All right. So just to kind of get us forward, a slow institutionalization of racism into our medical practice in America. So we have to understand there were separate white physicians for slave patients versus white patients. They wouldn't go to the same doctor. And it was believed that slaves' bodies were physiologically different. Our skin was thicker. We were made to work outside. We're more tolerant to pain. So thus, seen as almost that veterinary medicine was practiced, which also led to, well, we are allowed because they are subhuman or different than us, we can experiment. So I'm sure everyone knows James Marion Sims, right? We tend to think about that torturer, also known as the father of American gynecology. But many slaves he wasn't alone. So many of these physicians treated black enslaved individuals as experimental subjects. And so this expanded the physician's knowledge and reputation, but led to mutilation and death. So what links the legacy of racism to the structural and institutional aspects of racism in health today? I know I said racism a lot there. But sometimes we talk a lot about social determinants of health, but that's actually downstream from structural determinants of health, which I've alluded to right now. So structural determinants of health, that's our legislation, our public policies, civil procedures, practices, cultural norms that shape social determinants of health. And that eventually will shape the health of individuals in the communities we serve. So the key is, when you legislate it, you put it in a textbook, create public policies, that's your redlining, civil procedures. We can see this in our justice system. You think of a system that you see actively, that's active in your everyday life. It can impact someone's health. And we'll go into some examples here, such as education, access, and quality. So luckily, Serena Williams, well-educated, she had great access to health care, but the quality dipped a little there because they dismissed her concerns. She lived in a great neighborhood, was at an esteemed hospital. She had good social support. She's well respected and loved, and she had significant economic stability as a millionaire. So just think about all that in the young teen mom who has been kicked out of her home that doesn't have any of this, didn't finish education, doesn't know where the nearest clinic is, or maybe only gets her care where? From seeing someone like me in the ER. I am not the best spot to get your OB care. I am there, I can handle an acute delivery, I can tell you, no, not today, or, oh, you are over 20 weeks, you can go upstairs. I do like saying that a lot. So the past is prologue. The history we were not taught in school lies at the root of contemporary health inequities. And I'm going to go through a slide that's going to look very busy, but I bet there will be some laws there that you never knew that our government created, and the purpose of creating it was not to improve our nation. It was really to subjugate another group and reduce their access to land, quality of care, education, and even more. So, inequity was hardwired into America's legislative and policy landscape, particularly our healthcare system. So what I'd like people to kind of look at here, we have slave codes back all the way to the 1600s. As I said, 1910, we had the Fletcher report. This is what led to the closure of black hospitals and medical schools in the segregated South. We have the Immigration Restriction Act. We have the Homeowners Loan Act. That's the beginning of redlining. We actually have had multiple attempts to have universal health care. But do we know a reason why we often stymie it? It's not so much because of capitalism. Because if you have health care for all, who does that include? People of color. People that they are trying to legislate from not having equality. So, our government has been involved in this for quite some time. We have had some success in trying to create another policy to remove, such as like the Civil Rights Act, where we tried to get things a little bit normal, but even that, we're saying we no longer need aspects of it anymore because we have equality under civil rights, which we know is not true. So, let's bring it to our topic today, and I know I'm running short on time, I'll try to go quickly here. How institutional and structural racism raise stillbirth risks. So, one thing we have to think about is Black, American Indian, and Alaskan Native birthing people are more likely to deliver at lower quality hospitals. The site of care explains a meaningful share of adverse outcomes. So, unequal access to high reliably obstetric units. This leads to what I don't use as often, but obstetric racism, which can create harmful care delays. So that's your dismissed symptoms, delayed evaluation, for decreased fetal movement, and biased triage. Then we have structural conditions. So this is your segregation of neighborhoods, and this correlates with still higher stillbirth risk and widens that black-white gap. And this mechanism includes care deserts, cumulative stress, and environmental exposure. So this is, why, there's another reason why climate change is important, right? Because extreme heat, air pollution, poor quality drinking water, that also factors into fetal mortality. If you can't have clean drinking water, you can't trust the food you eat, you can't trust the air you breathe, that's not gonna do great things for your baby in utero. These are things that can be addressed through policy changes, but often sometimes is ignored. And I just thought, before I go into my next slide here, common health conditions of concern in the Black community. And I'm gonna focus mostly on heart disease and high blood pressure, because that often has the biggest effect with birthing mothers. So heart disease, still very much #1 killer of Americans. The rate of disease has been decreasing due to medications and the American Heart Association, and always just keep lowering a little bit more what is considered somebody that's hypertensive. Everybody remembers the 140 over 90 days. We're like, oh, I'm not gonna get near that. And now half of you in the room are like, darn, I just hit 30. How am I already gonna have to get started on a pill? So, Black Americans don't necessarily have more heart disease, but are more likely to die from heart disease due to a delay in care, those deserts, its difficulty of even EMS access to their neighborhoods, or a lack of preventing the progression of disease. So, sometimes many people don't realize that African Americans aged 18 to 49 are twice more likely to die of heart disease than other Americans. And the ACA, which has actually come up in the news quite a bit over the last 10 days, to address this disparity. Hypertension, biggest risk factor for heart disease. 1/3 of Black Americans suffer from hypertension. Actually, when you get to Black adults, it pretty much goes to 50%. So if you're in a room with Black adult, pretty much Black folks, I would pretty much say if you're over 40, 50% chance they have hypertension, and they may not even know it. Which then, if you have uncontrolled hypertension, not only increases your risk of heart disease, but also stroke. Many Black Americans will develop hypertension early in life and thus goes undetected for many years. I took care of a UPS driver, great family man, and when I used to work in West Virginia. And he came in with left-sided hemiparesis, and it was rather acute. I tried to clot bust him. We were too far away from sending him to a tertiary care facility. He was admitted for a while, eventually transferred him out through rehab. But he didn't have a college degree, but he was the main breadwinner in the home. He, like I said, was only 42 years old, had 2 kids. Wife had a job at a bank as a teller, but so much became impacted and he hadn't been to the doctor in 3 years. So he had uncontrolled hypertension that predisposed him to an early stroke in his 40s, led to losing his job, waiting years to get on disability, ended up hampering his marriage quite a bit. Kids made it very difficult for them to be able to leave that area to go on to college. And you can see the bigger effect just from not controlling one's blood pressure, say for a Black community leader, or just for several Black men in the neighborhood, that can lead to increased morbidity and mortality. That can further make it harder for a community to do well. So, comorbidities are not destiny though. All right, we are not defined, even though I just gave all that information about how this disproportionately heart disease and hypertension is more prevalent in the Black community. Hypertension disorders, diabetes, and growth restriction contribute, however, but the disparity persists after you adjust for that. So this implicates the care pathways and racial bias more than biology. So that's what I want you to take away from that. Yes, it's more common in Black Americans, but when you adjust for that, where they live, that's the Serena Williams, right? They're still likely to end up succumbing more to racial bias and a care pathway that's impacting their healthcare outcome. So, what good care looks like and where bias creeps in. So we have evidence-based prevention and surveillance. I'm sure many here are familiar with low-dose aspirin for those that are preeclamptic, particularly if they're at risk for preeclampsia. Starting that earlier is better. Starting off in 12 to 28 weeks, ideally less than 16. The key is to ensure equitable identification and offering of low-dose aspirin. And some of these risks being rigorous response to decreased fetal movement. When I ever saw fetal movement in the ED, I am not sitting around waiting to get a confirmatory ultrasound. I'm calling an OB immediately and probably skipping over the OB and like, who's the MFM on call? But I have seen this a bit more because I practice a lot of critical access facilities, right? So I take care of those that are below the poverty line. Quite a few Native Americans from northern Arizona to Wisconsin to other parts of West Virginia. These are often in care deserts. So not my first time, but I know how to react. Bigger, larger institutions, they may not have a protocol set up if you are able to see something, so a woman coming in with decreased fetal movement, or they clearly don't want to say stillbirth because they don't want to scare someone. Or a concern for a future stillborn. But antenatal testing, growth surveillance for those indicated risks. Failure points, under referral to MFM. I want to give our MFM more work to do. They get paid well. Late or missed testing, and unequal counseling and induction planning when they're near term. This often tracks with hospital quality and a part of a cause of this is implicit bias, not offering everyone the same care. So, solutions that move rates now. Publish stratified perinatal dashboards, but I think we stopped doing that in the state, right? Because we don't need to show how healthcare birth and healthcare outcomes for women of color are doing. I think also at the CDC, they're going to stop reporting it eventually. So we're going to be relying on other sources on collecting that much of that data, because that's seen as divisive, right? Not addressing the problem. And route Black and Alaskan, Native, and American Indian patients to higher quality L&D units when feasible, and deploy equity huddles for abnormal fetal testing. It doesn't necessarily need to be done at the floor level, but it really needs to be done by department chairs. and they need to possibly be a section of a M&M that someone's having, where they actually address, was equity in care performed here? And then use standard decreased fetal movement protocols. Clinical practice, recognizing social determinants of health screening with warm handoffs. I see that done at several institutions I practice at, where the nurse is actually doing a social determinants of health assessment. Often we as insurance plans will partake in this as well. Equitable aspirin and screening and uptake, and timely, like as I said, MFM referral, and shared decision-making on timing of birth. So what can we do to increase marginalized communities to trust the medical system? So of course here, we have a lot of reasons for why African Americans don't trust the medical system. Mistrust goes well beyond Tuskegee. A lot of people like to reference Tuskegee syphilis and not treating black men with syphilis in Tennessee. But we had Marion Sims, but also unethical medical research towards African American children as recent as the 1990s. I can give you that reference later. People probably didn't think it went that far forward. Unethical, all right? And good thing that we have some ethics committees that are part of many institutional boards. And then the codification of racism through Jim Crow eras that persisted into the late 1980s. So, trust is vital. Foundational element to therapeutic doctor-patient relationship. Without trust, the patient decision to seek help early or seek preventative care will only diminish. And patient satisfaction supports the notion that fear of race-based discrimination, this is once again, fear of interpersonalized racism, will be impacted or possibly met if they seek care from their local clinic. What we want to do is we want to try to turn around what we can to build trust in the community. So part of it is by practicing anti-racism. That is educating yourself. This is part of the education today, but it shouldn't stop today, and it shouldn't start again in February next year, right? It doesn't just go away for a little while and come back every few months. It's systemic. It's been here for a while. Our foundation is on it. So educate oneself on cultural rules and norms, I often say. Even I need to do this, especially because I've done some cultural faux pas with Southeast Asian communities and Native American communities that I had to learn. And someone corrected me on that. Didn't embarrass me in front of the patient, but they pulled me aside later when I was in the nurse room. So you can't, that's very judgmental what you said there about their cultural beliefs. So we are the Sioux people. This is how we take care of our elders. Please be respectful. We didn't expect you necessarily to know that, but if you're going to take care of our folks, read up on us. Humanity. Seeking humanity in others is at the heart of racism. So we need to make sure we are humanizing. There's some dehumanization that's going on right now that unfortunately we're getting bombarded with a lot in social media, right? Definitely some people many times can say the dehumanization of immigrants in our nation and people of color is occurring with some of these unlawful arrests. And then allyship. That's what I'm doing here today. And I want many of you here to take away this. Take on the struggle as if it's your own and commit to taking risk. And the key here, because I'm doing this as well, trying to bring up the next generation of black doctors, I have to share privilege and access. People in this room that have privilege and access, part of anti-racism is sharing it. And then improve, what can we do to improve patient-provider relationships? Treat patients as experts. This is a tricky point because we don't want someone coming in with their chat GPT or Copilot readout to tell us what we should do today. But listen to them, say, all right, yeah, let me hear that. Okay, it makes some good points, but how about we use this plan, all right? It still brings in some aspects of shared decision making, but make it so that the patient's making the decision and not the AI. Choose empathy, not arguments. Remember, some people want to see you. Most people don't want to see me, all right? No one wants to say, hey, I want to go to the ER today. There are some people like that if they have maybe a substance use disorder, but most people don't want to see me. And I know that. There's fear and anxiety. That's 50% of what I treat. Build a relationship outside of the exam room. If you're in a close-knit community, such as some of these critical access facilities I work at, this can be done, but not always expected. But becoming a healthcare provider that's a community leader, that can help. Because I practice in Arizona and Minnesota. I don't practice in Utah, but people come to me to seek medical advice regularly because I put myself out there educating Black and marginalized groups on how they can take better care of themselves and or advocate for their provider to do their job to take care of them and be a part of the institutional change. Ways to increase trust, attend affordability and access, address affordability and access barriers, safe, welcoming, warm environments, and signal a commitment to improving patient experiences. What have we done to address some of these inequities? We need for cultural sensitivity, need systemic reform. So in your institution, hopefully there's a reform board. If someone has at least asked the question, do we have any practices that, or systemic practices that disproportionately that lead to poor outcomes for those that are from a marginalized background? Maybe we should look into that. And then addressing systemic racism. Once again, I said a holistic report, addressing our curriculum. Educating our future healthcare providers is key to this, because when it's happening by the time they're attending, I don't want to say it's too late, but when they're out of training, and which means it's some of this bias is ingrained as they've gone along. And if they're hearing it from me in their 40s, they're like, oh wow, I did all that. I didn't know I did that. So it needs to start so much earlier because it's committed by residents. I see it. Yes.
Sorry.
Yes.
Do you mind going back one slide so we get a picture real quick on the building trust one? Yeah.
That one?
Yeah. Thank you.
Oh, that makes me feel good. I put something good there. All right. Did you get it?
Yes.
All
Thank
right.
you very much.
But I want to get time for questions. So one thing that I do want to bring up is the ACA. As much as it was voted to be defunded and dismantled, it still exists. The ACA and its expansion actually it was one of the biggest legislative policy changes that occurred in our nation to try and reduce this gap in care. It increased access to health care since 2013. It's been stalled. They're doing their best to erode it. I think they voted 45 times to try and do away with it, but nothing to replace it. I think 20 million people now gained access to health care because of this. But the gap between Black and white adult uninsured rates dropped by 4 percentage points, while the difference between Hispanic and white fell by 9.4 points. But disparities narrowed in both states that expanded Medicaid eligibility. Utah took a little while to do that. I think it was, 16, 17 when they finally accepted it. And in those that did not, which we know are certain states in the Southeast and the Southwest, all three groups had better overall access to care than they did in non-expansion states. So what I mostly want to see here is how, when we kicked off with the ACA, people had they were more likely to be insured and they have greater access to care. Black adults living in expansion states are now less likely to be uninsured when white adults compared to white adults in non-expansion states. So that's pretty significant, which will, in a matter of time, improve healthcare outcomes. However, there are still forces that don't like equity, unfortunately, in our institutions. So my call to action, if place and bias predict stillbirth, then changing place and practice must be our intervention. Commit to tracking, standardizing, and moving patients to excellence, not asking patients to out-navigate in equity. Because that's often what we say, well, you can do better. Here's a couple forms, here's a handout. Go to this address, this clinic will probably see you. That's all I can do. This is BPOU. It's October, so if you have not scheduled to get your mammogram or getting your annual exam or performing self-breast exams, I highly encourage that. All right, thank you.
We would love to take a few questions for Dr. Ferguson. Please raise your hand. Ashley.
So you talked about the mistrust within just general medical care, but there's also a lot of mistrust within research for not only Black women, just the Black community in general.
Mm-hmm.
Do you have any specific suggestions for talking to like people about research? Because I know that when I read a research study, the likelihood that there's someone that looked like me in that study is extremely low.
Yeah, so this is actually a great point. So I've worked, are people familiar with the Utah chapter, Delta Sigma Theta? It's a historical black sorority. So some of their leaders have reached out to BPOU and we've partnered. One of them is a researcher, I want to say with Huntsman, and they realize, and I've realized as well, you need at least one person that's a community leader that you're trying to do, if you're trying to do a clinical trial or trying to recruit more African Americans or someone from marginalized groups in that clinical trial, getting someone from that particular community to be part of the trial. Either as trained as coordinator to assist in recruitment, but they need a little buy-in because it's like, well, what are you doing with my information and data? So I think that's probably the biggest thing that I would tell a larger institution is have someone, they don't necessarily need to look like them, that does help to gain that trust or at least to access the community. But if someone says, well, I want to be able to do a study within Salt Lake County to see if those that are in Kearns and West Valley and Harriman, if their air quality is impacting their blood pressure. Well, how are you going to try and reach those communities of color in those areas if you're a Huntsman Institute or University of Utah researcher? You're probably going to need the assistance of a provider in the community that has access to where many of those people will meet, congregate, pray, worship. That's how you often will start and say, hey, I want you to be part of our advisor to our clinical trial. So it's the I know better. Why would I ask someone that isn't a healthcare professional? But you need to bring them in or else you're going to be shut down. So that's one way to do it. And possibly having a small stipend or, studies shouldn't be free when people are taking blood and, possibly giving them medication. And there needs to be if something doesn't go well, they need some type of assurance that if I have a bad outcome, what's my recourse? So knowing recourse, having someone that represents the community that can be an advisor as you are trying to tell them about a research study. That's what I would say. Good question. Yes?
One of the solutions that you suggested was referring to better quality hospitals.
Mm.
And it occurred to me that, in a lot of my transfers, I might transfer someone to a hospital or refer them to a hospital that all of my experiences have been positive. Are there ways that we know how hospitals are doing as far as equity work, or that I can maybe front load, or say like maybe we should go to this other hospital that's done some more work?
So I'm trying to think of the reporting right now. Of course, when someone that credentials hospitals or brings hospitals like as the payer, we use CMS and a star rating. That's what we use, and for quality of care. So if we get enough grievances at a hospital where someone's complained about mistreatment that appears to imply racial bias, sometimes it doesn't get that granular. They just look at this person had a worse healthcare outcome and race is never identified. But we can tell if they're just bad outcomes, period, but we're often the qualitative reporting either has to start at that institution if they think they're doing something wrong or if they want to do better, as opposed to waiting for the federal government to receive complaints and give a rating to an institution, which is how things work right now. So I would say NCQA reporting and CMS to get quality metrics for a hospital or a clinic. That's about all you can really do at this time, unless that institute, because I don't know of a nationalized reporting system that will address, that measures health inequities for particular communities that may go to that hospital. It's just outcomes, period, for that hospital.
You said one of those was CMS, and what was the other one?
NCQA. They have ratings, star ratings for hospitals and clinics, mostly hospitals.
We'll take one more question, sorry. We can't keep Dr. Ferguson here all day. Anybody else have a question?
Thank you for your presentation, your work and your service. I was wondering if there's anything that you saw, that you've seen in your work as a serviceman that you wish was actually applied, providing care in that setting versus in the academic setting. Is there any best practices you see over there that you wish were replicated?
Yeah. I have to say, the best thing I liked about when I was practicing overseas, taking care of families and service members, particularly outside the U.S., but it happens in the U.S. as well, is often who I reported to was not a doctor. It was another serviceman, often a colonel or a general, but usually a colonel. And they said, whatever you can do to maintain morale, keep our families healthy, and keep our soldiers safe and healthy as well, and to retain our fighting force, I will cover it. So I didn't have to deal with prior auths. They just trusted that I knew, and they weren't worried about costs of care. Mind you, when you think about the DoD budget, do you think it's aircraft carriers and submarines and bullets and fuel? That's a big part of the DoD budget. Why would the DoD budget be different than what our largest debts are in our own nation and what we spend on? It's healthcare. But I would say the fact that I was able to provide adequate care is I wasn't questioned about waste and if I was doing the right thing. Now, if I ordered an MRI on every soldier that bumped their knee, someone would probably flag that and go, all right, he's still walking, and did you use your Ottawa rules? Like, it was kind of strange. But my colonel, I didn't have another doctor questioning me. It was often someone that was, let's just call it an administrative leader, is who I had to go through. And they didn't have a medical background, but they trusted their doctor that was taking care of because I often took care of anywhere between 1,000 to 5,000 soldiers I was responsible for. And we had a lot of protocols, and that Intermountain loves, I don't know if the EU loves them as much, but there's a ton of protocols that we followed a lot that experienced physicians would integrate into this socialized healthcare system, which is the military medicine that I'm a product of. So it often worked very well. Anyway, great question. Well, thank you, everyone. I enjoyed myself. I hope you enjoyed.
So I'm introducing three speakers. Sunayna Wahi is a research manager in the Department of Obstetrics and Gynecology at University of Utah Health, and she works in partnership to support our center's Equity Core. And Sue is also the manager of the Culture, Resilience, and Community Health Partnership Departmental Committee. And her interests include representing health disparities through the use of geospatial tools, working towards culturally competent and community-supported decision-making, and identifying barriers faced by people of color in women's and maternal health. Our next speaker will be, and I'm sorry, I might have these out of order, so apologies, but Naomi Riches. Dr. Naomi Riches is a research assistant professor at University of Utah Department of Obstetrics Gynecology and a member of our Stillbirth Research Program and the Placental Insufficiency Working Group. Naomi's research includes identifying and addressing the needs of stillbirth parents related to post-mortem decision-making, as well as examining the impact of air pollution, climate change, and social determinants of health on adverse pregnancy outcomes, including stillbirth. Dr. Riches, or Naomi, is an active member of the Center of Excellence in Exposure Health Informatics and the NIH National COVID Cohort Collaborative Social Determinants of Health Working Group. And then our third speaker in this session is Melannie Green. Melannie has a decades-long history as an active volunteer within the Utah community. As the mother of 7 children, she's been given countless opportunities to serve others at her children's schools, local churches, and businesses, as well as with many organizations. She's served as president, chair, and volunteer with Share Parents of Utah Pregnancy and Infant Loss Support since 2013. She's an executive board member with Utah's Festival of Trees, a contributor to the CDC Department of Health and Human Services SOARS, or Study of Associated Risks of Stillbirth Committee, and she served on the International Stillbirth Alliance University of Utah Conference Planning Committee. So those three speakers, I think I have Naomi up first, so I'll hand it over to you. Thanks.
Okay, thank you. How do I forward?
This is it's just on my screen, so just click.
Okay. So hi everyone, my name is Naomi, and today my title of my talk is Decision Support for Stillbirth Evaluations, Improving Decision Making for All. So I'm going to focus on how stillbirth evaluations fit into the bereavement picture, how equity challenges shape access to these evaluations, and then how decision support tools can help families make informed values-based decisions. So in the US, approximately 1/3, and is even as high as I think 50%, someone said earlier, of stillbirths have an unknown cause associated with it. And stillbirth evaluations are strongly recommended for determining the underlying causes of death by professional organizations like ACOG and the Society for Maternal Fetal Medicine. So they recommend placental pathology, fetal autopsy, and genetic testing based off of 2 studies that were conducted to determine the usefulness of different types of stillbirth evaluations. And you can see the results here in this table. So Korteweg's team, they conducted a study in the Netherlands where the aim was to identify the optimal workup after a stillbirth. And they enrolled a large cohort of a little over 1,000 stillbirths. Dr. Page and her team, they're local, and they used data from the Stillbirth Collaborative Research Network and found about 512 eligible stillbirths. Now, each stillbirth in these 2 studies underwent a standardized protocol for evaluating the cause of death. Both Korteweg and Page determined a test as useful if the results were either established or helped to establish a cause of death. Of all of these tests they assessed, placental pathology was found to be the most valuable test for determining cause, with up to 95% clinical utility. And this was followed by fetal autopsy and genetic testing. So together, all of these evaluations can give families the clearest picture possible of the cause of their stillbirth. And these evaluations offer several other benefits. They can help inform the management of future pregnancies, identify health concerns in mom. They can correct misattributed causes of death from an initial diagnosis. Even in the case of inconclusive results, they can provide value by ruling out suspected conditions. So now that we've seen how the value of these evaluations, let's talk about why they're not always done. So despite clear clinical guidelines and the recognized value of stillbirth evaluations, only 21% of stillbirths in the US get an autopsy. Both patients and providers face barriers to stillbirth evaluations. For patients, they might have personal values that are a barrier, such as they want to protect their baby from harm. It's a highly emotional time. It's also a time when providers may not want to discuss with their patients because it is very uncomfortable, and parents may be given the wrong information. For example, we recently discovered that our consent document had a little something in there that talked about how they might be charged for the cost of an autopsy, and now that we know this, we're working to fix that. So other barriers can include distrust of medical providers, just like Dr. Ferguson was mentioning earlier today, believing that no new information will be uncovered. And some families worry that autopsies might prevent funeral services or that the procedure might disfigure the baby. And these misconceptions, along with the cognitive overload from acute grief, can lead to decisions that don't align with a person's long-term values. So providers also face challenges. These include limited or no training in bereavement care, not having up-to-date information about the evaluations, like I said, that discomfort in discussing these evaluations, and some providers are skeptical about how useful the examinations actually are. So as a result, some providers will avoid these critical conversations, and this leaves patients feeling excluded from the decision-making process and struggling to make an informed choice. Another common issue is that providers don't have the time to consult their patients, and not surprisingly, this poor communication and lack of timely information leads to overall lower health care satisfaction. So let's shift to equity challenges. The rates of autopsy and genetic testing do vary widely by race, ethnicity, socioeconomic status, and geography. This is in part due to those system or institutional level barriers that Dr. Ferguson was talking about earlier today. Things like cost, limited insurance coverage, limited time, and clinician bias. In rural areas, there are a lot of times issues transporting the baby to a location that can actually do an autopsy. And then nationwide, there's a shortage of perinatal pathologists and genetic counselors. These barriers are further compounded when they're combined with low health literacy. And these patients often have a harder time understanding the medical information. They're less likely to be comfortable even advocating for themselves. And low health literacy can also decrease participation in the decision-making process altogether. All of this leads to worse health outcomes, and it's more apparent among minoritized and lower socioeconomic individuals who are also dealing with other disparities. The consequences of this inequity are that families without access to comprehensive evaluations may never get an explanation for their loss. This can prolong grief, and it's also a missed opportunity to counsel for reoccurrence risk in future pregnancies. And on a population level, what this means is that inequities limit our ability to identify preventable causes, and as well to reduce disparities in stillbirth rates because that data simply isn't there. For those of you who provide care in the room, you may feel uncomfortable approaching your patients during this highly emotional time. You might find it even more difficult to bring up the topic of autopsy. But what I found when interviewing stillbirth parents is that they really appreciate having clear information so that they can make a decision that fits their values, whatever that decision is. And to be clear, I'm not saying that we need to push these patients to get evaluations, but not giving them the opportunity to make this decision because it's uncomfortable to talk to them can reduce patient well-being in the long term. So one tool that may help in these difficult conversations is a decision support tool. These are also sometimes called decision aids. These tools are structured, evidence-based resources that help families understand what their options are. They can explain each of the evaluations, the information that they can yield, as well as any sort of limitations that might exist. And these can come in any format, like a booklet or a video. A decision support tool for stillbirth evaluations can also present less invasive alternatives such as imaging or a partial autopsy if a full autopsy isn't acceptable by families. Now, this comprehensive framing empowers families to make choices that fit their needs and beliefs. And so my team and I helped create this decision support tool, and you can see this is the cover page right here. In our decision support tool, we acknowledge that this is a very difficult time, that patients should take the time that they need either to spend time with their baby or to make this choice about their autopsy decision. We provide information about the different levels of autopsy as well as placental exam and genetic testing. This decision support tool isn't intended to replace the conversation that all of you providers have with their patients, but it supports this often uncomfortable conversation. And it can take the pressure off of the provider and onto the booklet to find the right words. So what this might look like in practice is that a provider hands their patient the booklet as they sit down to counsel the patient. It's a very beautiful booklet. I didn't design it. We had a professional company do that. Every page has very few words, and the language is very simple, so it makes it easier to focus on. And the patient can follow along while the provider reviews their options with them. And the physical act of turning the page can provide even a little bit of comfort. If they are too overwhelmed to really hear what's being said in that moment, they have this to refer to later. So patients are also exposed in this last panel to quotes from other stillbirth parents that either chose to get a stillbirth or declined a stillbirth. Came out wrong. Chose to get an evaluation or declined one. These quotes help bring the patient's values into the decision. So now decision support tools.
Question about that.
Oh yeah.
Why do you give this booklet to them?
So we're actually still haven't evaluated it yet, and we're hopefully going to do that in another study so that we can make this a universal tool. But this ideally would be given sometime before, like after they've learned about the stillbirth, but before they have to make the decision. Labor and delivery is often a good time because there's enough time for a lot of patients who are just sitting and not doing anything. You don't want to give it right away because shock needs to kind of wear off a little bit. And I think for us as researchers, we're still trying to establish that kind of ideal time, and that might just be different for every family. So it's a really winding answer, but.
Yeah, and when is it going to be published? Like, will we have access to it?
So this this decision support tool is actually in the resources, I believe. Yeah. No. Oh, time. Okay. Sorry.
It's on the Stillbirth Center website.
There's a PDF
PDFs
version.
on it.
Yeah.
So cool.
Yeah.
For the center here.
Okay. Utah Stillbirth Center of Excellence.
Utah, what is it?
Stillbirth Center of Excellence.
Well, and so decision support tools can help reduce disparities by standardizing information that every family receives. They can be translated into multiple languages, presented at appropriate literacy levels, and they can include culturally sensitive framing. And this ensures that all families have equal opportunity to make an informed decision across all the different evaluation options. There are some implementation considerations. I might skip that because it looks like we're running out of time. But in summary, if implemented well, a decision support tool could be a key step towards improving decision-making, reducing disparities in stillbirth investigation, and helping to improve data quality for prevention research. And this would be by increasing the accuracy of those causes assigned to stillbirth. And references, and I just like to thank everybody here, as well as my team and all the moms and dads who helped in the research that, sorry.
Thank you. All of the resources we are sharing will be available to you all. So, Sue, you want to come up? Just click here to go down. Okay.
Hi again, everyone. Can I just say it's great to be in this room, to feel your energy, and I feel a sense of really good community here today, and that always does me well. Thank you, Zan, for the introduction, because I always botch that up if I do it myself. I would love to talk about something that I got to work on together with my wonderful colleague, Stacey, Fletcher, who is the parent voice for our wonderful USCOE. I'll just keep it at that, short. I live for short things. And the co-director, Leisher, who we've heard from. So it's called Guiding Conversations. It came from Australia. I'll just touch on that briefly because I don't have much time, although I would love for you to read it in peace when you have all of the time to spend on it. This is an acknowledgement page that we have in the booklet, and I would like to read this off. We acknowledge the many families who have shared their babies' stories and lives in this guide, as well as the healthcare professionals who learn from these pages. We acknowledge that the black to white stillbirth rate ratio was 1.9 in 1950, and it is 2.2 in 2022, the most recent year for which national vital statistics are available, and that there are similar ratios for other groups, including Native Americans, 1.7 in 2022, and Native Hawaiian, other Pacific Islanders, 2.3 in 2022. We acknowledge the need for more data, research, awareness, and solutions to decrease our country's stillbirth and newborn death numbers. There are beautiful eucalyptus images throughout this guide, symbolizing resilience and strength, and so we have kept those also. That was some of the great feedback that we have received from parents. Similarly, we hope you will also find strength, resilience, and protection as you move forward in your own healing. We acknowledge that death is what brings families to this resource. We hold space for this tender and complex journey and send our support. Guiding Conversations comes from something called Care Around Stillbirth and Neonatal Death, a clinical practice guideline. Short, Cassand, again, short's my thing. First edition was released in 2008 in Australia. So our wonderful stillbirth adaptation team Guiding Conversations adaptation team, I should add, thought that it would be great to, pick our Australian colleagues, their brains, and see what they thought about sharing that resource with us here in the US. Before I jump too far ahead, the Guiding Conversations booklet is a companion resource designed to support parents and assist healthcare professionals to navigate the difficult conversation and to help in making the decisions around the time of a baby's death. It gives parents access to evidence-based information about care around stillbirth and neonatal death in a sensitive and an appropriate way. Guiding Conversations is based on extensive consultation with parents and healthcare professionals and follows established processes for developing parent-centered information. The two snippets that I have up there are from the website of the Stillbirth Center of Research Excellence in Australia. They have wonderful resources. You can click on them. They are live. You can download them just to see what they have done, as they are leaders in stillbirth work, and they have wonderful resources. On the left side, on the bottom, I would like to point out that they also have a parent version for Aboriginal families called Jiba Pepini, or Star Baby Booklet. Our approach was a collaborative one. We worked together with the original leaders who worked on Guiding Conversations Australia. Their names are Fran Boyle, Julie Dean, Vicky Flanati, Sarah Henry, and Christy Brewster. We had wonderful parent consultations to get their feedback on what they like, what do they want to keep, what do they want us to change, besides the obvious S's that need to be changed to Z's. We also got feedback from a number of clinicians, and I already mentioned our wonderful staff, and I should also mention Leanne, which is also here today. She was the glue. And we are also working together with the department, our Utah Department of Health and Human Services, and their study of associated risks of stillbirth. So these are a couple of our beautiful faces. I think, we always try to humanize everything that we're talking about. We got to hear wonderful numbers. We got to hear pieces of history, policy. But it never gets old to hear from parents, if I could just say it as it needs to be said. As I'm looking at these faces and these pictures, I think about the stories that some of the parents shared with us. I think about their babies, the names that they gave their babies. And every time I look at their faces, I think about what they shared. This is some of the feedback that I already touched on. So we kept the eucalyptus images throughout for their symbology, along with the central theme that was already in the booklet. Something that is just amazing was that we were able to add resources for fathers, for grandparents, siblings, and non-birthing parents and other family members, so that we couldn't add into our version of Guiding Conversations US, but we just added another booklet to it. So there's two booklets. And then we created an opportunity to incorporate, let me back up. What am I saying? This is what I wish. I wish that we had time to work on this before today. But we would like to work together on creating an accompanying tool for training on how to use this booklet in clinic. We were also asked to consider creating a culturally adapted version for the US that could tailor to the many different cultures that we have, not to say that everybody should be under the same hat. Is Dr. Ferguson still here?
He just left.
And we made sure that we added respectful and inclusive language in this version. So on the left is the table of content from the Australian version of Guiding Conversations. And in the middle and on the right-hand side are the two booklets that we got to work on. We have copies of them in the back, and it is also under the resources tab of our website. Excuse me. I promise I will not read through all of this, but these are just a few snippets from the Guiding Conversations draft US booklet. And on the left-hand side, a few of the things that we did differently was add in these little summary boxes that, you know, if a parent gets this booklet in hand and they don't feel like flipping through the whole thing, they can just look at a few of the summary boxes, and there's also boxes for parent quotes that really, you know, get to the core of the message, even if you don't get to read all of the text. In the middle, page 22, preparing for birth, that's something that we also worked on, adding in that, you know, you can ask if there are cultural birth expectations that the person would like to address. How do they feel about pain management? Have those expectations changed? And on the right-hand side is page 53, under other questions that parents might have about autopsy, placental exams, or genetic testing. We also spent significant time on creating this list. So the other booklet that we worked on, it became a second booklet, and that wasn't the initial plan. But we did feel like this was best because now there is a resource that you can hand to the non-birthing partner and take a bit of stress away from the birthing person, right? To put it on somebody else. Another question that maybe she doesn't have to answer. So we have included what we thought as necessary for parents who have lost their babies. We have pages for grandparents, and in the middle, we have a wonderful quote from somebody we also worked with. I would like to read it off. When I was a toddler, I had a sister who was stillborn at full term. Decades later, my niece was stillborn, also at full term. Through the heartbreak of my sister's loss with my niece, I realized the unprocessed grief we had as a family after my baby sister's death. Statistically, stillbirth can run in families, leaving generational impact. I hope that anyone who experiences this tragedy is given the grace to process and is offered support as they continue growing and raising their family. I already hinted at this. We do have the booklets here today for you in the back. If we have run out of them on the table, we have a few additional copies. And we would love to receive your feedback as well. We are still taking feedback, yes, to work on the next version, even though we have almost wrapped up this current version. Something else that we would like to mention is that we will be working at adapting it for culturally appropriate versions. Thank you for your attention.
Thanks so much. Melannie, we're running about 10 minutes behind, but it's all good. So Melannie is next, and then, yeah.
I can't be 10 minutes less. No.
So just advance by clicking here.
Okay. I'm honored to speak today. Our twins, William and Maximus, are my why. William died early in the pregnancy, and Max passed away shortly after birth at Primary Children's Hospital. Over the past 18 years, I have been given the opportunity to support, uplift, and ease others' burdens when their baby dies. I truly understand much of what others are experiencing. How have any of us in this room survived saying goodbye when we even didn't get the chance to say hello? Speaking to caretakers and support personnel in the room, I believe that your primary job is to empower parents to say goodbye to their baby in the way they see fit. Support them in their decisions and encourage them to do as their heart desires. I think it's important to note that not all decisions need to be made immediately. Spiritual beliefs will play an important role in the decisions that are made. Speaking to parents, your baby is your stewardship. Your baby does not belong to the hospital, the mortuary, the state, or even your extended family. By embracing this opportunity to make decisions that are in your and your baby's best interest, you will have less regrets. We'll talk briefly about budgets and what may play in the decision-making process when saying goodbye to your baby. Creating memories in the short time available is so important. I like to suggest that parents take the time to slow down, soak in every little moment and feature of your baby, and allow support people to come in and assist you. I don't claim to be an expert. However, I have been given the opportunity to support over 1,000 Utah families, and I have learned a lot through that process. I know for a fact that this has blessed my life as well as it has blessed theirs. Each experience that I have had with the family has been very unique, and every baby and family that I have served means a lot to me. I'm sharing personal pictures of times that I have been with families, and their lives have touched me in very meaningful ways. As a caretaker, you are not responsible to know about every ritual, belief, or tradition regarding those you serve. But understanding the importance of these customs can help you as you assist in guiding each family through their memory and decision-making phases. In that same breath, I have found many instances where a little nudge to go outside religious or customary guidelines can be healthy. I have personally been told that because of my advice, any preconceived notion walking into this experience was changed. Something as simple as taking a baby, a little naked baby, and placing a diaper and a hat and wrapping them in a blanket can take them from being a body to a baby. Parents should feel empowered to take photos if their heart desires. Oh, did I skip? I may have skipped. There we go. Sorry, I went too fast. Parents should feel empowered to take photos if their heart desires. I had an experience with a mom who desperately wanted photos of her baby, yet her cultural teachings forbade it. After a brief discussion over other cultural changes made in modern times, she decided to go ahead and take some personal photos just for herself to treasure. I'm not saying that we should push our own agendas, but find a way to help support, facilitate, and encourage what parents feel they want to do. Living with regrets can be tragic and devastating. Pictured here on this slide is me holding my son during his funeral. I think our funeral director about had a heart attack when I went over and picked him up out of his casket. However, I couldn't stand watching him just lay there for one more minute. I think we all needed for him to be held, rocked, and sang to while we said goodbye. My experience serving and supporting Utah families is that often it's their first close personal experience with death. They feel lost, and the decisions that must be made are daunting and feel confusing. Hiring a funeral director is typically the most comfortable option for most people. They can help us make decisions on how and where to lay our baby to rest, and they can assist in choosing a casket or urn, and often offer discounts or even portions of their services at no cost for babies. I do want to point out that it is not required by Utah law to hire a funeral director or go through a mortuary. If you would like to know more about this, the National Home Funeral Alliance is a wonderful resource. If budget is restricted, there are many resources available that can actually help save a lot of money. If parents and designated dispositioners are willing to do the legwork and paperwork, laying a loved one to rest can be done without paying someone. Included as part of my presentation is a list of Utah funeral homes throughout Utah. This list will continue to be updated as information becomes available. And I believe that this is also going to be made available to everyone here.
You want me to get back to it?
I think he's just X out, right? Oh.
No, it's okay.
No, I don't know.
Good.
Educating yourself on local city, county, and state laws can help you as you support families. Or in the case of parents, choosing to take care of all the details and saying goodbye on your own. For many of us, time is money, and hiring someone to help facilitate plans, abiding by codes, laws, regulations, and standards can be just as important. That being said, there is no one-size-fits-all. The door is wide open to many unique wants and desires. Decisions rooted in love are always the best decisions to make. Some important notes: with the right permit, a parent can absolutely transport their own baby, can take their baby home, and provide their own casket. Did you know that caskets and vaults are not actually required by the state of Utah? This requirement is a regulation by specific cemeteries, but there are a few cemeteries that offer green burial. In many areas throughout Utah, it is legal to bury your baby at your own home. When scattering cremations, a permit is not always required, but it's best to contact local city and county government to inquire about specific restrictions. All that being said, not all families have the means or even desire to bury their baby or take their baby's remains. The legal threshold for doing so varies from state to state and country to country. In the U.S., I think most of us in here are aware that a stillborn baby typically must be buried or cremated within 20 to 24 weeks gestation. Some hospitals may provide assistance and even approach families with the choice to have their baby donated to science. In the state of Utah, you can apply for a certificate of birth resulting in stillbirth for 16 weeks gestation through full term. In addition, you may apply for one of these certificates even if it has been many years since your baby was born. The process is handled by the Utah Office of Vital Statistics and is called delayed registration. Although both are worded very similarly, a certificate of birth resulting in stillbirth and certificate of stillbirth are not the same thing. Many parents, legislators, policy analysts, and state health departments agree. There is a subtle yet immense difference in the two. The MISS Foundation believes that all states should record births as births, whether live or still. The goal is that all states legislatively change the certificate to a certificate of birth resulting in stillbirth, which we view as a birth certificate. If I may leave 3 key takeaways with you today, I'd like to, 1, encourage you to help ease another's burden through service and genuine support. In my opinion, there is no greater pain than that of losing a child. Sitting with someone while they are at their most vulnerable will impact you both. 2, look for opportunities to serve your fellow mankind. As a parent supporting other parents my entire adult life, I will stand by this statement. Experience provides more knowledge than education. I've been able to connect with single moms, special needs parents, pregnancy and infant loss families, and those recovering from strokes, amongst many other things, because of what I have personally experienced. 3, follow your heart, your intuition. By finding the balance between logic and instinct, your compass will never leave you astray. I've had 2 experiences since our boys left that I would like to share. They're both pictured here. My mother-in-law passed away less than 2 years after Max, and since he was buried in her plot, they temporarily pulled him up to place her body beneath him. We took this opportunity as a family to take a few photos and touch the vault that holds his tiny little body. More recently, this past May, as we arrived at my father-in-law's service, I couldn't help but notice that our son's burial vault was once again exposed. I notified one of his funeral directors that once Papa was lowered into the ground, that I would jump down there. Because we had built such a good relationship with our funeral director, she didn't bat an eye. I knew that this would be my last opportunity to physically feel as close as I would ever feel to him again on this earth. Always follow your heart. Our oldest daughter, is the video on here? It's, I don't know. It's usually right there. There we go, okay. Our oldest daughter took this video and posted it to TikTok. The results speak for itself, with over 3.2 million people touched by this gesture and with over 4,000 positive comments. Even though his life was short, our experience loving Max is having an impressive impact on others. We will live life to the max. Thank you for letting me be here today.
Thank you.
Our branch has a passion for helping those in the face of complex pregnancy challenges, and he cares for his patients experiencing high-risk pregnancies. As a specialist in maternal fetal medicine, Dr. Brandt specializes in managing various conditions, including recurrent miscarriage, genetics, and fetal diagnosis and stillbirth. He is committed to achieving the best possible outcomes for his patients and is here to support you and your family every step of the way through pregnancy journey. I was asked to present something like personally. He's a man of few words, I think. But I did have the privilege of being shoved in a van with this man for an entire few days in Sri Lanka chasing elephants across, and we really got to know each other well. So it's all yours. Thank you for all that you've done with patients throughout the years.
As I say, I'm always doing my job. Thanks a lot.
You are.
Yeah, right. Can you hear me? Are we okay if I stand here? All right. I want to tell a story. That's why I'm here today. And it's a story about fetal loss. And it's a story about other complications of pregnancy. But most importantly, I think for this audience, it's a story about how investigative efforts can ultimately lead to solutions. So I want to tell that tale today. How do I change the slides? I don't know.
Push on the...
Push on.
I'll do it for you here. Sorry.
I can do it here. This is great.
Oh, there we go.
Yeah,
Just
there you
page
go.
down, yeah.
These are disclosures, and you'll see what that's about in a minute. So, a long time ago, not in a galaxy far, far away, but a long time ago, I was told to get engaged in a certain newly recognized complication of pregnancy that ultimately became known as antiphospholipid syndrome. And it was in the early 1980s that this autoimmune condition was recognized as being associated with fetal death, that is stillbirth, as well as with some other medical complications, including blood clots. International conferences about this condition started in the early 1980s, and I have attended the majority of those, most recently the 18th or 19th in Japan a couple of weeks ago. The name of this condition, as it's now known, antiphospholipid syndrome, was bestowed upon it in the early 1990s. There is our first publication regarding our management of a small number of cases to prevent or to ameliorate pregnancy complications. And so that's how we got started in this condition. Let me make sure I'm not missing a slide here. Yeah. Ultimately, in the late 1990s, the condition was classified by experts. So criteria were developed so that you can name the condition. And the criteria at the time, devised by a group of experts together in Sapporo, Japan, included either having had a blood clot in the past or an obstetric morbidity. And on the slide there, you see the obstetric morbidities. They are recurrent early miscarriage, otherwise unexplained fetal death at or beyond 10 weeks gestation. That, of course, includes stillbirth, and placental disease, preeclampsia, or placental insufficiency requiring delivery less than 34 weeks. So we came up with those clinical features. There are marker autoantibodies. I'm not going to talk about them much today, but there are marker autoantibodies for this condition. And if you want to keep the slides and look at them, you can. We remained involved in the investigation of this disease. We participated, I and a couple of my colleagues participated in a small randomized trial of steroid treatment during pregnancy versus low doses of heparin during pregnancy in an effort to prevent complications, including stillbirth. And it was the result of this trial published by first author Susan Kalchuk, you see, who, by the way, is now a rabbi. How about that? We participated in this, and the standard of care became the heparin plus the baby aspirin treatment. And we're going to talk about that a bit more in a minute. I also worked on intravenous immune globulin treatment as it might pertain to improving outcomes in this pregnancy. Yeah. And that study was negative, as were a couple of other studies done by others. And that is feedback. Am I doing it? No? Okay. All right. And that proved to be negative, so the standard became the heparin and the low-dose aspirin. Here's a classic case. This is it's a case of mine in the last couple of years. 27 years old, first pregnancy, and at the time, for the sake of the presentation, yeah, that's a good idea. Yeah, don't lose that thing because they're expensive. The 27-year-old, 26 weeks gestation. She has a previous diagnosis of antiphospholipid syndrome because she had an unprovoked blood clot in the past and she has all the marker antibodies. She's treated during the pregnancy, thoughtfully, I think, by the folks taking care of her with low molecular weight heparin, which is the modern day heparin compounds, and the baby aspirin, low-dose aspirin. And she's been treated since early pregnancy. So now she shows up with features of severe preeclampsia. She also has fetal growth restriction and all of the features that we can identify ultrasonographically of a failing placenta. And if we left things alone, what would happen to that fetus? It would pass away in utero, and it would ultimately be a stillborn. Having identified the condition, the team of care providers said, this is a bad problem, we got to get the baby out, and we did so, and a 26-weeker was delivered. I want to make the point that this situation occurred in spite of the standard treatment, And what has emerged over the last couple of decades is that the standard treatment is not quite as good as we want it to be. Our team participated in this study run by Jane Salmon in New York. And in this prospective observational study, we followed patients with either lupus or this antiphospholipid syndrome, or both, and some controls. We followed them during the pregnancy. We didn't tamper with the treatments. Their care providers treated them, typically, if they had antiphospholipid syndrome, with the heparin compound and the low-dose aspirin, right? And we did a bunch of patients. And so what we found, I'm not sure I can point. Can I point to this? Do you see that? Yeah. Oh, yeah. What we found is we enrolled 496 patients ultimately, which was not bad in my view, given that these are relatively infrequent conditions. And in those 496, there were 21% of the patients had an adverse outcome as defined at the bottom of the slide. And that adverse outcome could be a fetal demise or a neonatal death due to complications of prematurity. And what we found was that the adverse outcomes were best marked, I should say, by the presence of one of the autoantibodies that's known as a lupus anticoagulant. I think it's a stupid name, but that's the name of the antibody, sorry. There you go. And the red bar there represents the adverse outcomes on the y-axis. The red bars are the ones with lupus anticoagulant. So it turns out that in this condition, which is characterized by clinical features, including prior stillbirth, the worst marker is this lupus anticoagulant thing, and it's one of the autoantibodies. So what we have found is that patients that don't have the lupus anticoagulant and who get treated typically with an aspirin and a heparin compound do pretty well. And that's great news. But those people that do have the lupus anticoagulant have a suboptimal pregnancy outcome around 40% of the time, in spite of this standard treatment that was sort of designed, started in the 90s. So, what do? Patient comes to see you, like the last case, the one I showed you, 26-week pregnancy delivery to spare the case from stillbirth, so to speak. Patient wants to have another pregnancy. What do? Well, over the years, we have tried a whole bunch of stuff sort of empirically. And by the word empiric, I mean we thought we would just try something, right? And that happens to be a fair amount of American medicine. Let me just point that out. But well-designed trials were lacking. There has been promulgated a mouse model of this condition that was used to come up with some ideas. And in the mouse model, the pregnant mice were injected with serum from either a healthy person or serum from an antiphospholipid syndrome person, so that the antibodies are now in the mouse. And doing that creates a model wherein pregnancy loss is pretty common. And remember, the mice have multiple pups, right? And it turns out that in Dr. Salmon's lab at Cornell, in that mouse model, if you block in the inflammatory response, the ability of that mouse, by various mechanisms, you block the ability of that mouse to generate inflammation at the interface between the mother and the placenta, the APS doesn't kill the fetuses. Now that's kind of cute. That's kind of neat, isn't it? Now, I think the mouse model has its problems. The mouse model was originally described here at the University of Utah, by the way. I think it has its problems, but this was the existing evidence. Dr. Sam, in Jane's lab, she and her colleagues showed that an initial event in the murine model, an initial event is complement activation, that is an immune activation at the interface between the placenta and the fetus and the uterus. And part of that cascade, remember, inflammatory cascades are complicated, they're not really simple. Part of that cascade is is the elaboration of TNF-alpha, that's tumor necrosis factor alpha, and the accumulation of white cells in the tissue, in the placental tissue. So inflammation is going on, is the point, in this mouse model. And Berman, her people showed that if you block the TNF, and there are agents available to block TNF that are used for rheumatoid arthritis and Crohn's disease and psoriatic arthritis and that kind of stuff. If you block the TNF, you also improve the pregnancy outcomes in these mice. Now that's a good thing to know because TNF blockers are out there and they're FDA approved for certain autoimmune diseases. Now all of this information was available in the late 1990s and early 2000s. So one day I had a patient who had previously had a mid-trimester stillbirth and that was in spite of treatment with the heparin compound and the low-dose aspirin. And this was a well-informed and bright patient, and we talked about things. And this patient, I guess the right word is, insisted on another pregnancy. She'd never had a child. So at the time, there was one TNF blocker on the market, and we talked about that, and we decided to give it a shot. Now, I don't want you to think that we're totally nuts here, because the TNF blocker, this one, had been used in pregnancy before but in patients that had rheumatoid arthritis or Crohn's disease. So we weren't just completely nuts. So we did that. And she has 2 kids. And that's a great thing, and she shows us pictures of them and that kind of stuff. But that's an N of 1, and that's not a study. So what we did then, Jane Salmon and I got together and had 2 glasses of wine, and that's the key thing here. That's the key thing. And we said, we got to do this thing. So we put together the impact trial. This was over a dinner in Atlanta, as I recall. And it was a long time ago. And so we hypothesized that if we added TNF alpha blockade to the standard treatment, we could reduce the rate of adverse outcomes as defined on the slide, the primary outcome. You see it there, guys? We could reduce the rate of the adverse outcomes by 50%. Now, when you sit down to design a study, you make up some numbers based on your best evidence, to be sure. And so, to a degree, we kind of made up a number, 50% reduction in adverse outcome. And then we wrote a grant, and then we sent it to the NIH, and we sent it to the FDA, and we did all the things you do. And we got approval, and we got some money, which is really key here. Please, no one in this room forget that about further studies in stillbirth. Please do not forget that. And Jane in particular is an excellent fundraiser who's really well plugged. She's a senior rheumatologist, and she's really well plugged in with, say, the Lupus Foundation of America and others. And the pharmaceutical company helped us a lot, and I think we're indebted to the pharmaceutical company. It's a rare disease study. It's a single-arm trial. Everybody who's in it got the drug. We had historical controls from the PROMISE study. Remember the ones where we just watched to see what happened? And so we decided to do it this way, and we could talk forever about study design. We're not going to do that. You had to be pregnant. You had to have the lupus anticoagulant, that bad marker. And we started the study, and we got patients from around the country. And a slight majority of the patients are from Utah, but quite a number of them from the New York area, and Jason Knight at Michigan, and some other players that helped a lot. Well plugged in hematologists, rheumatologists, and MFMs. I'm an MFM. So, what we did was we screened 76 people, we enrolled 51 people. So we started with an intention to treat group, as they call it, of 51. And in the next box down, second up from the bottom, you see the modified intention to treat group. And that's the group we're primarily going to discuss very briefly anyway. The reason there's a modified intention to treat group, as you can see to the right-hand side, there were some patients who enrolled who lost the pregnancy in the first trimester, miscarriage. We did not think we were treating miscarriage, so let me be clear on that point. And people do have miscarriages, right? And then some of the pregnancies were lost because of genetic abnormalities, and these are what are the words? Standard, well-known genetic abnormalities that can cause fetal death. So we didn't include those people in our analysis of the study outcome, right? Does that make sense to everybody? Okay. So I want to characterize the patients a bit to let you know that it's a very high-risk population. So almost 20% of the patients had lupus, and 70% of them had a history of blood clots. So this is not a benign population of folks. And you can see, though 88%, third from the bottom, 88%, I should use the pointer, shouldn't I? 88% had a history of obstetric morbidity that's characteristic of antiphospholipid syndrome. And so this is a high-risk population. The most important part of this slide is right here. A history of a live birth surviving to hospital discharge. Under 40% of the patients in the study had a baby. So it's a high-risk group. This immune condition is a problem. So here are the primary outcomes from the trial. This is published a few months ago. And in the middle one, third over from the left-hand side, the modified intention to treat group, of which there are 45 patients, the primary adverse outcome rate was 20%. So 80% of the patients did great. So we were thrilled. And that met our statistical goal of a reduction from 40% to 20%. Now, there's no such thing as a perfect treatment for all disease, that's for sure. And one of the patients in the 20% category had a classic antiphospholipid syndrome stillbirth. But many patients had their only baby as a result of this trial. So we were thrilled. And we're carrying on with that. We still can enroll patients thanks to the pharmaceutical company. As you may know, the federal government is not working anymore. So we don't have any money from them. By comparison to the old patient populations, that first column, second column from the left is our adverse outcomes in the 45 patients. And so the adverse pregnancy outcome rate in the impact prior treated pregnancies, that would be the impact eligible prior treated pregnancies, would have been 69%. 70% of the time those patients had an adverse outcome, compared to 20% with the treatment, and so forth. I won't belabor it because I want to get on to something else. The idea that immunomodulatory drugs might improve pregnancy outcome has made the news in a different sort of way other than the IMPACT trial, and I want to bring that up as something that you should perhaps know about. So one historically well-known cause of stillbirth is alloimmunization to red blood cell antigens, Rh disease, right? And so for eons, people have noticed hydropic stillbirths. They didn't understand what it was about, but it's been described for thousands of years. I think probably 3,000 years, actually, because it had to be written down. Right. So anyway, and here on the slide, you see what the mechanism is. That in this case, we're talking about an Rh negative mother, upper left-hand diagram. And the mother bears a child that's Rh positive instead of being Rh negative, right? And during the pregnancy or at the time of delivery, the fetal blood cells get into her circulation, and she makes antibodies to those red blood cell antigens, to the Rh positive antigen on the blood cells. So in the next pregnancy, she's making these antibodies that cross the placenta and attack the baby's blood cells. And that's how the Rh disease works. Now, it turns out that there are other red cell antigens besides those in the Rh group. That's not the point of this conversation. I just wanted to give you the example. Ken Moise recently published in late 2024, a study of nipocalimab, a monoclonal antibody. Remember, I'm using a monoclonal antibody called certolizumab in the IMPACT trial. It's an immunomodulatory antibody. This also is an immunomodulatory antibody. And what it does is when you give it to a patient, it dramatically drops their antibody levels, their IgG isotype antibody levels, to about 35% of normal. And so the concept here was that Ken wanted to take patients who had bad outcomes from horrible allo antibodies that had previously resulted in pregnancy loss. And so you can see in their most recent qualifying pregnancy, live birth rate was 38%. So that's a high-risk group. And all of this due to the antibodies to the red cell antigens. In the study, he gave everybody the nipocalimab, and the IgG levels fell, including the antibody levels that were causing the trouble, right? And in the study pregnancy, 92% of the patients had a baby. So it's also a single-arm trial like ours. Different disease, but antibody-mediated disease. Does that make sense to everyone? So thank you for listening. I wanted to talk about successful investigations in the arena of stillbirth. Thanks. Yeah. That's it.
Does anyone have any questions that I can?
Go.
Brenda.
You said there's the funding may stop, but is any research still going on with this?
Yeah, so for our work using certolizumab, the drug company is continuing to fund additional recruitment. So that's very generous of them. Now, remember, the drug companies, they kind of have one thing in mind. And so that's just the truth. Dr. Salmon and I are meeting with them in 2 weeks at the American College of Rheumatology meeting in Chicago. And what I want to do is, that company also makes one of these FcRn receptor blockers, like the drug that Dr. Moise used. And I'd like to get hold of some of that and see if giving that agent would reduce the lupus anticoagulant levels in the patients before they conceive. I like that idea. And then that might be as good or better a treatment compared to the Cimzia, or maybe you use both together. But, so that's the answer to the question, right? But everybody in the room should remember to support investigative care, because that's how you learn to fix things. That's the message. Yeah.
Go ahead. I know one of the frustrations within the loss community is that criteria of having to have 3 losses before you're getting screened. Is there any changes coming to that, to where we can change that screening criteria to not have to lose 3 babies before we can
So the professional organizations that write about recurrent pregnancy loss include the European Society for Human Reproduction and Embryology. That's ESHRE, if you want to write that down, all caps, because their guidelines are free online. And then there's the American Society for Reproductive Medicine guidelines. And both of those sets of guidelines promote evaluation of patients with 2 miscarriages as the starting point. So I think if you were to come to see Dr. Silver or one of us in our group or me, we're going to evaluate patients right off the bat if they've had a second miscarriage. Now, we could talk for a long time about miscarriages, and I'm happy to do so outside this room and so forth. But I think we're not waiting for 3. When you write classification criteria, like you saw in the Sapporo classification criteria that I showed, please remember that the reason for that has to do with research investigations more than with face-to-face clinical care. And that's important because you don't want to, how do I say this? When you classify patients for studies, you want to be creating a relatively homogeneous population and not grouping a whole bunch of different kinds of cases together, because then you confuse the outcomes that you're measuring. And so classification criteria are different than professional guidelines for clinical care or different than face-to-face interactions with patients. Does that help?
Yeah, just in my experience, I think a lot of the parents here would say that many parents have had that clinical experience, so have not agreed before.
Nah. The rules are, the guidelines say 2 for clinical care. Classification criteria, different problem, different issue. Yeah.
There was one more question.
Yeah, how do patients get diagnosed with APS? Is that for like regular prenatal blood draws? Is this?
So typically the patient goes to see a doctor because of a blood clot or a stroke or some medical malady or severe preeclampsia, stillbirth, and the informed clinician says, oh, this could be antiphospholipid syndrome, I'm going to do the tests. That's how it usually works. So
we're only going to catch it if they have a problem.
That is correct. A frustration to be sure, but that is correct. One interesting aspect of what you've brought up is, at a study we did here some years ago, Karen Gibbons is the first author, we drew blood on all the patients that would allow us to draw blood who came in with preeclampsia or placental insufficiency with severe features to the labor and delivery area. And 11% of them are positive for antiphospholipid antibodies. And so one way of perhaps preventing a next pregnancy bad outcome is to think about your presentations even in a routine setting, like an average labor and delivery room suite. And if the patients have these features that raise the possibility of antiphospholipid syndrome, test them. So that's our tendency here, of course. These are not terribly expensive tests. That's an important point. Yeah.
I was just wondering on your outcome-based slide there that showed improved number of births. Do you have more information to share on the percentage of those that were premature babies and at what gestational age? Because that outcome for families is obviously...
I don't have it in one of these slides, and I can't remember the exact number. So there were 6 cases of preeclampsia requiring delivery before 34 weeks, which is, I don't think, ridiculously unexpected in this high-risk population. And then of the cases that went beyond 34 weeks, most of them went to 36 plus weeks, but it's a patient population who is sitting there with their doctor in, name a town somewhere, and everybody's so anxious at 36 weeks that there's a lot of iatrogenic early delivery going on too. And it's really hard to characterize those other outcomes in terms of the need for a delivery prior to, say, 39 weeks.
Yeah.
And you can imagine how that might be the case.
I'm a mom of 3 preemies. Yeah. 36 weeks gestation is a very good gestational age with
the mean gestational age of delivery was like 36.7 or something like that. I can't remember the number. Okay, I'm standing between you and lunch, guys.
Thank you. Thank you guys very, very much. Thanks, Ware. So I'm honored to now introduce Our second keynote speaker, Dr. Kathleen Massmann, holds a PhD in Advanced Studies in Human Behavior with a specialized research focus on stillbirth and post-traumatic growth, as well as a master's in mental health counseling. Her journey into the field of bereavement care is deeply personal. After the unexplained loss of her son Jacob in 2011, Dr. Massmann became a passionate advocate for providing competent and compassionate support to families who've experienced this heartbreaking loss. With over 15 years of experience, Dr. Massmann's expertise centers on grief, bereavement, and navigating pregnancy after loss. She's a licensed professional clinical counselor with a focus on pregnancy and infant loss, as well as grief support for families experiencing this profound pain. Dr. Massmann is also a certified compassionate bereavement care provider through the MISS Foundation, a certified stillbirth day doula, and a certified perinatal loss provider. As the founder and CEO of Healing Moments Counseling in Minnesota, Dr. Massmann offers specialized counseling services to support families through their grief. And in addition to her clinical work, she's an international speaker and the owner and CEO of Psyche Consulting, a firm that provides training and education to community organizations, mental health professionals, and medical providers across the country. And I had the great privilege of hearing her speak at Mount Sinai, I guess last year in New York City, and I'm so happy to welcome her here today. So thank you so much.
Thanks, Ann. Good afternoon. Can everyone hear me okay like this? Great. I'm going to walk around a little bit. But thank you for being here. I'm so honored to be here today and to get to talk with all of you a little bit. I'm going to take you on a little bit of a different journey today. I'm going to talk about some gaps in bereavement care that are really from my own experience. There's so many important experiences that deserve space for their story to be heard, and this is just one of them. So I hope that you'll take a little bit from this journey. I want to let you know that there are going to be some pictures of my son throughout this presentation, so if that in any way, shape, or form bothers you, or you just need to step out, please feel free to go ahead and take care of yourself. So just a little agenda, an introduction, we already did that, some primary goals. I'm a big research nerd, a lot like Stacey, and so we're going to just go through a brief research timeline of what do we know about how bereavement care has been done historically, what do we know about what worked, what really didn't work. And then perinatal grief and healing. So the stories I'm going to tell are going to talk about how those gaps presented themselves, but it's also going to talk at times about the healing that came from those. And then a multi-generational impact in those gaps. So hopefully when you leave, you'll have a little better understanding of historical and current research, knowledge on multi-generational impacts, as well as increased knowledge on grief and healing, and how to support those experiencing loss. So we all know this, 1 in 4 pregnancies end in loss. This is important to start to my story because about not even a year ago, I was at a conference in Albuquerque, and I was talking to the director of a university program, and we were talking about adding a course on perinatal and neonatal bereavement for their students. And I've sort of been hounding her for the last few years. I got to nail her down in Albuquerque and I asked her about it. She said, well, Kathleen, you have to understand, it's just so niche. So I'm really not a confrontational person by nature, but I can tell you something kind of snapped inside of me. Because first to begin with, we're talking about 1 in 4. I'm not great with math, but that's 25%. So this is not scientifically based or anything, but let's just say we have 25 stillbirths and we have 50 parents. And that's 100 grandparents hypothetically, minimum. That assumes we have like typical 2 grandparents per parent. Let's say we have 50 siblings and 50 friends. That means the potential impact is 275 lives, or 11 per loss. And this is incredibly conservative. And so we had this discussion about the fact that this is in no way, shape, or form niche. Now, I do think we get to feel better about ourselves when we think it's niche, because then it's this little problem that we don't really have to dedicate time to. So, I'm still waiting to see how that conversation pans out for me. All right, my timeline. So we're gonna go way back to 1976, which as I get older, I realize like that's 4 years before I was born, and not super flattering to call it way back anymore. But Klaus and Kennel talked about a lack of physical presence. And really what they talked about is that when there was a lack of physical presence, we created the formation or disconnect for stillbirth parents. And so they weren't really connecting with that baby versus they weren't connecting what they imagined the baby to be. And so Klaus and Kennel were the first ones to really look at that. And that research really highlighted the importance of physical presence between parents and child. We can sit here today and go, well, of course. But really, that wasn't anything they thought about in the 60s and 70s. After Klaus and Kennel published that work, Kirkby, Best, and Kellner completed follow-up research and found a connection between the care parents received in the hospital and their ability to process grief. And so they were really finding these pretty decent connections between how people were doing from a mental health perspective, from an overall wellness perspective, depending on how they were treated in the hospital. And then Lewis came along in '79 and really just acknowledged that often stillbirth was greeted with silence, and that many professionals and family members believed that a lack of discussion and recognition would allow the parents to move on more quickly. So basically, if we don't talk about it, things will be better faster, right? It was commonplace for moms at that time to be immediately separated from their baby and not allowed to engage in any parenting rituals whatsoever. They noticed cognitive dissonance, not just in these parents, but in the medical providers. So what they noticed is that when they went back and talked to the doctors and nurses that worked with these families, they were much more likely to remember parents who had a live birth than parents who had a stillbirth or a neonatal death. Stringham, Riley, and Ross, and I apologize if you know any of these people and I'm butchering their names. They looked at how women experience stillbirth, and research by those authors show that these mothers in the study were granted time with baby and allowed to parent them through acts of touching, bathing, picture taking, and that experience in many ways led to the initiation of their grief process and also their parenting process. In the study, the researchers found that none of the parents who spent time with their child regretted that decision. Not a single one, and those of you who do research or even don't do research, to have a study show that no one regretted it, it was huge. So Stinson, 92, I love Stinson's study because he started to look at the differences in gender and bereavement and how they were presenting differently, not just how they were presenting differently, but how we were treating them differently. And so they looked at how gender differences inherently bias how grief is measured in bereaved parents. We know that in general, moms are more likely to share their grief with emotions, share it with others, while dads traditionally maintain a more closed-off approach. The difference can very well and does lead providers to many times ignore the needs of dads in these situations while focusing on moms. That perceived difference in grieving has certainly influenced how we as a society treat those bereaved parents. There's a grief scale called the perinatal grief scale. I actually used it in my dissertation. It's not a fantastic scale, but if you do any work with these scales, you'll find that there aren't great scales to work with bereaved parents. And one of the problems with this scale is that if you read through it, what you'll notice is the questions are heavily biased on a maternal reaction to grief. So questions such as, how often do you cry? How intently do you cry? Things like that, where we're probably not going to get a great picture of most fathers from some of those questions. Wonk, Cacciatore, Scheffler, and Pritchard, 2017, they looked at miscarriage, stillbirth, and child death, and they found that parents who experienced stillbirth were the only group that had a lower self-esteem after the loss. So it's super interesting to me because what I hear from a lot of doctors from time to time is we don't want to scare moms. We don't want to give them too much information and scare them. But what this study really did was showed that when moms and dads were given more information, there was actually less of a self-esteem hit that took place. And so we have some really cool research that sort of is opening the door to the idea that we know more information is better anyway, but that it might actually preserve self-esteem when things do happen.
Can I ask a question on that? Is that like information about why it happened? What kind of information are you talking about?
Preventative information usually. Yep.
Okay.
Yep. So if they looked at all other kinds of loss, miscarriage, perinatal death, neonatal death, they didn't see that self-esteem piece. And there's a lot of speculation that part of that is because women will often blame themselves after any sort of perinatal loss, but in particular with stillbirth, there might be feelings of guilt of baby wasn't moving, I didn't think baby was moving, I talked to my doctor perhaps, they assured me everything was fine and I could come in the next day. And so there's a lot of speculation that that self-esteem hit could be due to some of those pieces. Cacciatore and Thiemann looked at how perinatal grief often results in psychological trauma, misunderstanding, and that it's common for clinicians to diagnose parents with major depressive disorder only a few weeks after their loss. It's actually really heartbreaking for me as a clinician to have a new client come into my office, sit down, and let me know that they were diagnosed as having major depressive disorder before they left the hospital, which doesn't even meet the criteria, and they were given an antidepressant to go home with. So, and certainly that's not all clinicians. There are wonderful, wonderful clinicians out there, but we have work to do on this end. And then the last one, Westby and his colleagues, their research provided a foundation for understanding the impact of mental health predictors within this population. And we really found that, like, predictably, social support, really important. And then the number one predictor of doing well after a loss was satisfaction with their relationship, whether that was a marriage or a partnered relationship. So I found this little video, and it's actually my favorite video to use with this presentation because when we think about gaps in bereavement care and we think about generational impacts, this is exactly what I'm talking about. There's not a single piece that moves that doesn't impact the next piece. And so today I'm going to focus on fathers, grandparents, and siblings. Just a little graphic. And it was really meant, these two, there's one after it, to illustrate that this really is very circular. So you're going to have great-grandparents impacting great-grandparents and grandparents, parents, children, and grandchildren. But my experience has been that the focus is here. And if we're really lucky, there might be some focus here. But typically, we're not seeing any focus anywhere else on that continuum. And then in reverse, of course. So, generations of loss. This is my story. My great-grandparents, amongst them, experienced 2 infant losses. We don't have a whole lot of information on what that means from them. Grandparents, 1 stillbirth, 1 miscarriage. The children, 1 infant loss, 1 stillbirth, 10 miscarriages. And my children, so the grandchildren in this, unknown, and the impact is immeasurable. The scariest part for me in this work is I have no idea what that's going to look like in 20 years. All right, grieving fathers. So I'm going to read this quote real quick. If you've ever lost a child, then you understand more about hell than anyone could possibly be expected to know. And that's from Kelly Farley in Grieving Dads to the Brink and Back, which if you have not read that, if you don't have in your list of books for dads, it's a fantastic book. The first time I read it, I absolutely hated it. And I actually talked to Kelly about it, and he said, go read it again. And so I went and I read it again, and I understood why I hated it the first time. It's because it was written by dads, for dads, and I couldn't relate to it at all. But the dads I work with find it very helpful. So with dads, how do they grieve? We tend to see this inward expression, fathers often grieving in silence, keeping their thoughts and feelings to themselves rather than seeking out help. They use work as a coping mechanism. Many fathers use their job as a way to stay busy, manage their emotions, and that can lead to feelings of loss of fulfillment in their work if they don't feel like they're able to perform the way they want to be. Can it lead to feelings of isolation? Feeling loneliness and isolation are common, sometimes stemming from a reluctance to upset other people or to ask for support that they're needing. Delayed emotional intensity, alternative expression of emotions. Some fathers find solace in hands-on activities. If you know about Faith Lodge, it's a bereavement lodge that you can go to for a retreat when you're a lost parent. And the first time we went there, we walked in and the women went and decorated journals and the men went and did some woodworking project, which for me was sort of this perfect example of I had no real interest in going and doing anything with woodwork, but my husband did. Yeah.
What was that place called?
Faith's Lodge. Faith. Yep. If you've never heard of Faith's Lodge, wonderful, wonderful place. They do retreats every week for bereaved parents suffering a loss for a variety of reasons. It's in Wisconsin. Challenges and misconceptions. Oftentimes, a father's grief can be overshadowed by the mother's grief, not because the mother desires it to be overshadowed, but because we tend to cater to a mother's grief more than a father's grief. Societal expectations. Be stronger, go back to work, take care of your wife, do these things. Minimizing their own feelings. Oftentimes because of those elements, those pressures, fathers will minimize their own feelings in the loss process. And then how to support a grieving father. Acknowledge his grief. It's so simple. It's what we talk about in general, but it's the major difference when we talk to dads is they feel that their grief wasn't acknowledged. So acknowledge their grief. Offer support in his way, in a way that feels congruent to who he is as a human being and as a parent. And create a support environment. Support environments can look very, very different for dads. A while ago, someone sent me a video of a father's bereavement support group in the UK. They go and play soccer. So it doesn't look like most of the support groups we run that are usually inhabited by mothers. So find ways for fathers to express their grief. Involve him in decision making. Encourage self-care and understand the impact. So this is my husband, and this is our son, Jacob. When I asked him a little bit about his story and how he felt some of these things fit for him, I will say he was resistant. But some of the things he mentioned that I wanted to share with his story was that as much as I love community partners and organizations, in our case, he felt utterly and completely dismissed by our community organization. In some ways I did as well, but him more than I. He would make suggestions about the funeral, suggestions about burial, and it would be dismissed. He was never asked about or involved in decision making, not medically and not about the funeral or our wishes afterward. He was told by family and friends that he should be strong, that he needed to take care of me. He was given almost no supportive literature or resources. At the time, so 2011, he got a little book about this big, and that was it. Everything else was for me. And he was told we should go home and have another baby. What I will say is the bright side of his story is he had an incredibly supportive work staff, which is amazing because he's an electric engineer. And if you know any electric engineers, they're not always great with their feelings. But they were incredibly supportive, gave him as much time as he needed off from work. So that would be one of the silver linings I would put out there. All right. So grieving grandparents. Grandparents are one of my favorite people to talk about because they are such a gap in this situation. And in addition to being a gap, they are expected to be one of the major support systems within a lot of these situations. So grandparents are grieving multiple losses: the loss of a grandchild, the loss of their child, who is never ever the same again. The person they've known their whole life isn't that person anymore. And the potential reemergence of their own loss story, and we're going to talk about that. They're the primary support, so they're trying to support their children, their grandchildren, but who's supporting them? There's a generational difference, potentially their own trauma reaction, their own loss history, changing relationships, friends that don't quite understand them anymore, and their own struggle finding support for themselves. All right. So I'm going to play a 2-minute video, and these are Garrett's grandparents. I'm just going to exit out of here because I'm not going to watch the whole video.
I got many babies to learn these lessons.
the role of the grandparent is there's a duality to the grief that I was not prepared for. I was heartsick that we weren't going to be having a grandchild to bring home. But I think maybe even harder than that, even to this day, is the grief that we watched our own children suffer. The pain and the anguish. And this wasn't a boo-boo I could kiss away or put a Band-Aid on. It was so gut-wrenching to watch Lindsay in particular, and of course our son-in-law, but even our son was so devastated by this. And all we could do was just hold each other. There wasn't anything that we could do. And
so that's just a little clip. Shauna and Steve are amazing. Oh, sorry. And just really exemplify that they were grieving their grandchild, and they were also watching their daughter and their son-in-law lose what mattered most to them in the world. All right. So this is my son, and that is my father-in-law, who is my grandparents' age. There's a generation gap between my husband and I, and so I always struggle because I want to introduce him as my grandfather, and he isn't. My son Jacob was born on January 15th, 2011. Sadly, our doctors missed what we believe was a congenital diaphragmatic hernia that ended up being fatal. I can tell you with certainty that the idea of infant loss had not even entered my mind at that point. Not once in my family had ever even been spoken about. And the same was true for my husband's family. It was, in every way, like being sucker punched. In the days that followed, we invited friends and family to come to the hospital to meet him, say goodbye, and hello all at the same time. And amongst our visitors were my in-laws. At this time, my father-in-law was 91 years old, and he was suffering from stage 4 multiple myeloma. So he was not a well man at the time. I should also mention that my father-in-law was one of 12 siblings. His youngest sister died of what we assume was SIDS, but really had no name at the time, and it was never talked about. Shortly before he came, I had sort of prepared myself for him to come in his typical stoic way and really not engage very much, not hold him, not look at him. That felt like a really possible situation for me. So I was quite prepared for that. What happened is still one of my favorite memories of my whole life. This man who had lost his baby sister and was struggling just to survive sat down in the rocking chair, opened his arms, and asked to hold his grandson. For about an hour, he held him, rocked him, cried, and asked God why he didn't die instead. Later, he insisted that my son's picture join the wall of grandchildren, there are 24 of them, in their home. This is where things got complicated. My mother-in-law never touched my son. She never looked at him. And she absolutely forbid a picture to go up on that wall. After several months, we decided we would put up a picture of his footprints. And that seemed to satisfy both of them as much as we could. In the years that followed, my mother-in-law rarely mentioned my son. My father-in-law died about a year later and talked about him frequently. In 2015, my brother-in-law and sister-in-law experienced a stillbirth. As we walked our own grief journeys, we joined the grief of our siblings, and we carried our personal family tradition to our extended family. We bought ornaments every year for Jacob. We still do. So we started buying ornaments for my sister-in-law and brother-in-law. My mother-in-law never said a word, not about any of them. In 2019, we went to visit my mother-in-law. Sitting on the table was a letter. In her typical and direct German fashion, she told us to read it, stating we were never to talk about it after that day. The therapist's brain in my body lit up, knowing that she, of course, wanted to talk about it. Well, I wish I could find that letter and read it to you today. A recap will have to do. In the letter, she told us that after she had all 4 of her living children, she entered into what she thought was menopause. One day, while going to the bathroom, she shockingly and heartbreakingly delivered a stillborn baby, likely about 20 weeks. a baby she didn't even know she was carrying. It would have been 1970. There were no resources, no one to call, and no one even spoke about such things. So she blessed the baby and buried it herself. She told no one, not even my father-in-law. She carried the secret on her own for 50 years. So why now? Over the course of almost 10 years, she had watched her children lose 10 children. She watched us grieve, she watched us remember, she watched us memorialize. She witnessed us talking about those children, speaking in public about them, and educating others. She watched us buy ornaments. At the end of the letter, she wrote, "I'm telling you this because I want an ornament for my baby this year. I want to hang it on my tree." In a single moment, all the pieces came together for me. Her perceived coldness, her indifference, her unwillingness to attach. Her baby had died, and she had carried that death alone for almost 50 years, while all the while watching her children bury their own children. Her loss, her grief, still prominent in her heart and unknown and unacknowledged. How could she possibly have acknowledged my loss? So on Christmas Day 2019, there was an ornament that hung on her tree, baby Massmann. She decided not to name her baby. The pride in her eyes that day is something I'll never forget. So, telling you this story is sort of multifaceted. The gaps in support that existed to such a great extent kept her locked in that grief for almost 50 years with no one knowing. I cannot imagine not having even told my husband about what I had just been through. And she kept it all to herself. Just to wrap up that story, healing comes in all shapes and sizes. But in our family, and for my mother-in-law, who's Bernie, it came through an ornament. Just before Christmas in 2024, my mother-in-law passed away after a 4-year battle with lung cancer. She was in hospice in our home when she passed. We had amazing conversations in those last years. This woman who couldn't even look at my son 13 years ago now wanted all of her grandchildren, alive and deceased, mentioned by name in her obituary. She wanted them represented in the flowers at her funeral. A white rose for her grandchildren she was going to meet, and a red one for those who would join her one day. When I asked if she wanted her child mentioned in her obituary, she gently told me no. I'm at peace with all of you knowing. We honored her wishes, and I could see the peace in her eyes. She had found the courage to tell her story. And in doing so, she found a healing that I don't know that she imagined she would. When she passed, I can only imagine the homecoming that awaited her. 11 people she never met, but always loved. 1 child and 10 grandchildren. Grieving siblings. I'm gonna take a few deep breaths too. That's my oldest. That's what he wanted to wear when he came to meet our son. And he came into that room like gangbusters. Like, he was so excited. He was excited to hold him. He was 15 months old. But to him, he was just meeting his baby brother. So with children, we need to be aware of extended grief responses. And I should also say, one of the really important things about perinatal loss and siblings is there's almost no research on perinatal loss and siblings. Siblings who experience the loss of a sibling, yes, but not perinatal or neonatal loss. And so we don't have a lot to go on from a research perspective. But we know they have an extended grief response. And by that, I mean, they don't know what they don't know yet. They don't know what it's going to be like to meet milestones, to go to high school, to go to prom. My son started driving this year for his junior year, and he got ready to go his first day, and he looked at me and he said, but he should be getting in the car with me this year. It comes in waves, and for them, it's very linear. They don't know what they don't know yet. Young children don't understand death or grief. That's the big myth. I'm not even sure how we can understand that. They just understand it differently than we do. We have a desire to protect our children. The challenge I have for people is, what does protecting your child look like in this situation? And only each parent can answer that question. For us, before we left the house, or before we left the hospital, we asked each other, are we going to talk about him? And the answer was yes. And in answering that yes, it meant we were opening the door and we were keeping it open, whatever that meant. And everyone has to decide that for themselves. But it's a decision that has to get made. They need tailored support. They need to work with people who understand child grief. There needs to be a focus on family dynamics, and I would argue support for parents alongside of the support for siblings. There's an unexplored impact. I still don't know how much his death will impact my children. I just know how it's impacted them thus far. There's an absence of guidelines. As counselors, if we look at grief with siblings who experienced a perinatal loss, there's nothing for us to go on. There's a lack of time and support at the hospital. We had an amazing hospital experience with our hospital team. They had a shirt ready for him, a new shirt, they had a bracelet, they had a teddy bear with angel wings on it. But that's not everyone's story. That's not what everyone gets when they bring their kids to meet their sibling. And there are resource gaps. Dr. Catherine Gold once said, one of the most shocking things to me in the surveys I've done was that hospitals report they're often not talking to parents about some of the most basic elements of grief and loss. Normal bereavement on relationships, how to tell siblings, and how to return to work. I think that was perhaps the most disappointing finding for me, is that we aren't helping parents anticipate what to expect once they leave the hospital. And that would be my challenge from a hospital perspective, is educating parents and giving them resources also means helping them with who they're going home to. So a little sibling story for you. This is my spitfire of a daughter. You'll find out more about that in a minute. That's Patrick, who is just as excited to meet his sister as he was to meet his brother. Often when I think about generational grief and impacts, I think about the generations before grandparents, great-grandparents, uncles, aunts, and so on. But what about the generations after? Historically, little was discussed about infant and pregnancy loss. It's why I had no idea how much loss existed within our mutual families. The impact from me was limited until it touched my life. But what about siblings now? Things have changed quite a bit. Siblings are now a regular part of the pregnancy, loss, and the grieving process. Surely the impact will be different for them. Our son Patrick was about 15, 16 months old when Jacob was born. So while there are pictures of him, there's no tangible memory. Although if you ask him, he will insist to you that he met his brother when his brother was alive. And to be honest, I have decided not to fight him on that anymore. He has no tangible memories, but the generational and gender differences are present. He and his brother would have been just 18 months apart. And so he often wonders how his life would be different and what their relationship would have been like. Just 11 months after his brother's death, his baby sister arrived. They are as different as can be, but they both grew up knowing their brother, knowing grief, and knowing a feeling of missing and yearning. This is where the similarities end. Patrick, now 16, locks away his grief. He has since he was about 10. We only get to see it on Jacob's birthday. It's the day he sits, even at 16, in front of his brother's hope chest, and he meticulously takes out every single item. He looks at it, he looks at all the pictures, and comes completely unglued. I have never heard my child sob the way he sobs every year on his brother's birthday. Guttural sobs eventually give way to exhaustion, and when the day's over, I watch him lock it all up again, attempting to be strong. Now, we certainly don't do everything right as parents, but he lives with a therapist who does grief work every day, and he still feels the societal pressure to lock it all up at the end of the day. Catherine is not her brother. Many years ago on the first day of school, Catherine brought a picture of Jacob to school to share her family with her new class. When she came home and told Patrick, he was outraged. He felt betrayed. How could you take something so personal and share it? But Kathleen was different. She always was. She talked to anyone at any time about her brother. She would and still does tell everyone that they're Irish twins. That day's conversation ended with Kathleen telling Patrick that Jake was her brother too, and that she got to have a relationship the way she wanted to. Her grief and love can be seen throughout the year, while Patrick only allows it to be seen on those rare days. When Kathleen was in kindergarten, I was pregnant with our youngest. It was a spring concert, so the classroom had parents and grandparents and visitors. And a well-intentioned grandmother came up to my daughter and said, "Aren't you lucky your mommy's having a baby to come home to you?" And my daughter, without skipping a beat, confidently said, "Not all babies come home. Some of them die." And this woman looked at her and said, "We don't talk about those things in public." Now at this point, I was ready to engage in the debate. But I didn't have to. Because really without any shame or any concern, she looked back at this woman and said, "Well, we do in my house." And she went on playing. Generational differences, generational gaps, generational impacts. Another example, our first excursion to Target after my youngest was born. Packed all the kids into the shopping cart, finally getting out of the house, so excited. A woman approached her and looked at Kathleen. Are you ever amazed at how nosy people are, by the way? A woman approached us, looked at my daughter and said, "You are so lucky to have 3 brothers." I braced myself. Here it comes. "Nope, I have 4. "Oh, is one of your brothers at school?" "No." "Is one of them at home?" "No." "Well, then where is your brother?" "My brother's dead. He's in heaven." I guarantee that woman never asked anyone anything at Target again. Generational differences. Lastly, when I found out I was expecting after losing Jacob, I had this fear of a question I knew this child was going to ask me one day. Who would you have chosen? Me or my brother? Because the two of them could never have existed in the same time and place. My husband thought I was nuts. He's like, "She's never gonna ask this." I started preparing myself from the time I found out she was a girl. I can tell you now that those questions started being asked at the age of 8. His death will continue to impact her in both hard and beautiful ways. It will keep impacting her and tens of thousands of siblings who will go on to have children of their own. I wonder myself, how will her first pregnancy be different from mine? Will she ever have the blissful ignorance that I enjoyed? Or will this generational gap and impact shatter that? Make her more aware? Or have an unexpected and unknown effect? So that's my story. This is a little quote I end most of my presentations with, especially when I'm working with people who support parents, because I know it was true when I felt like I was locked in the darkness. And that is, bereaved parents are forever changed by infant and pregnancy loss. Each person they come in contact with becomes interwoven in their story and their child's story. We can't change what's happened, but each of us from the first contact to the last can shine a small light into the darkest of days to say you're not alone, we're here, and we remember. Thank you guys.
Time for a couple questions? You broke them. Yeah, Brittany.
Can you share how, when you have parents, what are some of the key things you tell them about speaking about the death with their young children? Because it's a huge gap. I could share what I know about what's said that I don't think is great, so I think sharing the good stuff.
Yeah, so first I encourage parents to decide amongst themselves, are you going to include this child in everyday conversation? Because especially when you have little ones at home, if you're going to introduce them, you're going to have to prepare yourself for the onslaught of questions and emotions that are going to come. I'm also a big fan, as a therapist and as a mom, of using real words with our children. Age-appropriate words, but real words. So we use words, and we encourage our clients to use words like died, dead. We don't use passed away. We don't use God needed an angel. We don't use any of those euphemisms, because oftentimes we end up creating other issues that we now have to address down the road. So first, decide what role they're going to play ongoing. Use real words. Utilize other forms of engagement. So that might be like play therapy models. It might be books. Books are one of my favorite ways to talk to kids about death, because it's approachable. I give all the kids I work with the books to take home. And it's something they can keep going back to and sort of build their own story into it.
Yeah. For supporting grieving fathers, how do you help them get past that initial, what I would call kind of ego phase of society's expectations for them to be able to actually sit in the vulnerability? Because all of that support sounds great, but I think of the dads that I support in delivery, and I don't know that they'd ever allow themselves, so how do you just give them that permission and support them through that initial step?
Yeah. So the initial step is really hard because it requires that they be there, right? Especially if we're talking about after loss in any sort of support capacity. So they have to be there, which might mean they genuinely wanted to be there. It might mean that their partner drugged them to the therapist's office or to the group. But I find the most successful thing, at least for me, is when I am able to get them to participate in something. So if they're still in the hospital, inviting them to help dress, inviting them to help bathe, take pictures, be a part of things. In my therapy office, I have them write letters to their child. And it works pretty well to get them engaged.
It's pretty similar. We do that in birth and have them like write their own birth story after session, so in a similar capacity.
Yep.
Thank you.
So when my son died, the hospital gave us, because one of my questions was like, how do I tell my kids this? And so the hospital gave us actually like a script on like what to say. Is that something that just like the hospital, like that's available for other hospitals to have like a script to give to other parents? Because I felt like it was really helpful, because I was like, I don't know how to tell them.
I would imagine it would be easy enough. Yeah.
If that was something available to the other.
I would imagine that would be something easy enough for a hospital or a delivery unit to partner with a social worker or a counselor or someone to help with a script.
To like explain like, what to do, because it was very like age appropriate for them, and because I was like, I don't know how to tell them, and it was so helpful to like read that and then kind of like go off of that.
And I even imagine this is a starting point, you know.
Yes,
everyone's going to change it a little bit.
I don't know, but it was like, use this language, don't say sleep, and like everything else.
Yeah, don't say
so
sleep.
helpful to have, and to explain to them in like an age-appropriate way for them to know. But I wasn't sure if that was like something that just they did, or if it was something that was just like more available for like every hospital.
I don't know if there's a standard template, but I know there's some hospitals back in Minnesota that do something similar. So, yeah.
That's all. Thank you. I was going to say on our, we keep plugging our resources on our center webpage, but the Guiding Conversation booklet specifically for dads and birthing partners and family, so that's a great resource. And then on the resource page, we also have a list of like some dad groups, like Sad Dads, Men and Men, Room 11 out of Australia. Star Legacy has a dad's group, PSI has a dad's group, so there's a lot of resources on that page that are really cool, so thank you.
Face Lodge also has a dads only weekend for retreats, so they do those as well.
So
thank you so
a huge
much.
thank you to you. That was amazing. This is a bit of a last minute session that we were able to add on the ACOG toolkit for providers for bereavement care. And so I'm thrilled to introduce, I hope you guys are there, Dr. Michael Belmonte. He is a complex family planning subspecialist and assistant professor of obstetrics and gynecology at Penn State. Michael's worked with the World Health Organization and as the Darney Landy Fellow at the American College of Obstetricians and Gynecologists as the National Spokesperson for Family Planning. And he's also the obstetric lead for Penn State's new Pregnancy After Loss Clinic. Yay. Sheila Reynoso of ACOG was going to be with us, but she's not feeling well, and so we wish her well. And then we also have Dr. Karen Gibbons on the line. Karen is an MFM at Oregon Health Sciences University and formerly at the University of Utah. Her research focus is adverse pregnancy outcomes due to abnormal placental development, including fetal growth restriction, preeclampsia, and stillbirth. And Karen is also the mother of her stillborn son, Sebastian. So we're really, really grateful to have Michael on, and I'm going to hand it over to you, Michael. I hope that...
The audio's off. So you'll need our audio.
Can you...
His audio's off.
Oh, Michael, your audio's off. We can see that it's off. There you go.
I can hear you now as well.
Perfect.
He doesn't know that you just did the intro.
Oh, Michael, sorry. I just introed you, and it's yours.
Ah, excellent.
Sorry.
Hello, everyone, and happy Friday. We're so thrilled to have a bit of time to introduce the ACOG Toolkit for Stillbirth Bereavement Care. It's entitled Supporting Patients Through Stillbirth Care, a Toolkit for Healthcare Professionals. Sheila Reynoso from ACOG was supposed to give the bulk of this talk. Unfortunately, she is ill and won't be able to be here today. But certainly if you have any questions or input, we're going to try and answer those questions at the end. And certainly if you have anything to share with ACOG, we'll include her contact information at the end of the presentation. So with that, we will jump right in. And so, just a bit of background. In 2023, ACOG received a grant from the Centers for Disease Control and Prevention to improve health outcomes for pregnant and postpartum people. One component of that project was to evaluate implementation considerations, particularly for the management of stillbirth, which was the theme of focus groups that occurred, two of which were held at ACOG's annual clinical and scientific meeting. ACOG and CDC are particularly interested in finding out more about OBGYN's awareness of and use of the management of stillbirth guidance, how it's being implemented, and really to identify specific parts of that guidance that would be most valuable, as well as any additional supplemental resources that may be desired. And so the goal is to take what we have learned from these focus groups to really inform future ACOG resource development. These focus groups were 1 hour, and they were convened to discuss participants' awareness of and use of the ACOG and Society for Maternal Fetal Medicine's Stillbirth Management Consensus document, its barriers to its utilization, and then certainly additional useful resources to find out what more may be needed. The focus groups brought together 16 fellows in a range of practices and at various career points, all of which were familiar with the document and had used it, as well as other resources to care for patients. And so the focus groups really focused on bringing to life a lot of the information that was laid out in the tables, figures, and boxes of that document, and that's kind of listed here. To really ensure that providers have practical recommendations and can actually put this information into practice. One specific area that we wanted to focus on was the support services surrounding bereavement care and the management of a subsequent pregnancy after stillbirth. And so that is what's listed here at the bottom. And so taking what we learned from the focus group, a summary of those findings are kind of listed here, where participants really felt that the principles of bereavement care and tools and skills really needed to be reinforced among ACOG members. And so the findings were then discussed at a clinical consensus committee on obstetrics meeting in October of 2024. It was kind of resounding across the board at that time that guidance for supportive services was really lacking and also differed really among all the member institutions. And so people had shared that sometimes the things that they learned and were doing were really learned along the way, and there wasn't necessarily consistency. And so a combination of that discussion along with the findings from the focus group really led the team with the idea to develop a toolkit that would encompass comprehensive information on how to guide and have compassionate care and conversations regarding stillbirth. And so from that, one of the committee members, Dr. Brisner, really helped to develop a clinical summary table that served as a foundation for the development of the toolkit in terms of how it was divided by the stages of clinical evaluation. We thought that the toolkit would be segmented in the same way and that we could provide guidance on how healthcare professionals can provide care throughout these various stages. And so when we're talking about kind of from here, the development of the toolkit, ACOG had a consulting partner, APCO, or the Association of Public Safety Communications Officials. And they helped to perform an overarching literature search and found that while there were some tools for patients, not really a ton existed in the realm for clinicians outside of A1, who certainly does have a catalog of amazing resources for obstetric professionals. ACOG then convened an advisory panel that consisted of myself and OBGYN, as well as advisors in obstetric and neonatal nursing, a bereavement doula, a lactation consultant, as well as the founder of Sisters in Loss, who is a woman who had her own experiences with multiple stillbirth and pregnancy losses, and that led her to found a maternal child health education company for Black women storytellers around pregnancy, infant loss, and infertility. Each member had the opportunity to review multiple drafts and provide their lens of experience and insight. The toolkit also then went through multiple internal reviews at ACOG with leadership, membership, graphic design, resource verification, and that occurred over the course of many months. This was also then done in collaboration with CDC, who they met with monthly to provide their own insight and feedback and review throughout the process. And so that leads us to the toolkit itself. And so as you can see, the table of contents is here to the left. But what you can see is that we kind of break up these conversations for each time point during care, from diagnosis to subsequent pregnancies. These conversations have sample scripts, such as the one here, as well as notes that can help guide the conversation and tailor care for each individual patient. There are various ways to access the resources, but this is the main page where the information is housed. Unfortunately, due to a lack of federal funding, we don't have plans to develop another version of the toolkit or to expand on this work, but the goal was, if funding had continued, was to see how this toolkit was being implemented across membership and, of course, other organizations. And certainly we're happy to share this with you today. I think the other thing to keep in mind, if Sheila were here, she would definitely say that ACOG is very happy to accept any feedback and personal experiences as people are starting to use the toolkit. And certainly in the case that original funding returns or funding is obtained from alternative sources, we certainly hope to expand on the work. I know that was a brief overview. I want to include kind of some of the resources that went into developing the toolkit, and then some other things that we have to support our members through these kind of clinical scenarios and discussions. Here's a list of people that were part of that team that I had mentioned earlier in developing the toolkit. And then I just want to thank everyone on behalf of Sheila and ACOG. Here's her email, so please don't hesitate to reach out with any questions, concerns, experiences as you use the toolkit, and certainly any feedback. And certainly myself and Dr. Gibbons are here to take any questions if you have them. I know that was pretty quick.
Thank you so much, Michael. Can you hear me okay?
It's a little quiet, but I'm turning you up. I think, there we go.
Okay, anyway, yeah, thank you so much. Are there questions from anybody about this brand new toolkit, which was just launched a couple of weeks ago? Yes, Brenda.
I'm on the ACOG website. Do you have to be a member to pull this up, or?
So, you guys, Michael and Karen, the question is whether you need to be a member of ACOG in order to access the toolkit. Somebody's on the website of ACOG right now and isn't able to access it.
Yeah, my understanding was that you did not have to be, but certainly I will look into that. But I would agree, this is something that we want to make widely available, and so even if you were not a member, we will make sure to get this out to people.
I can actually tell you that we've put a link to it on our Utah Stillbirth Center of Excellence resources page. I hope the link works.
It must be user error.
No. Other questions? Yes.
I work in the hospital in bereavement, so what is my role with this? Like, do the doctors already know about this and have access to this, or is this something that I can bring up to them?
So the question is from somebody who's working in bereavement care in the hospital, and what is her role in getting this, in using this toolkit? Would the doctors already know about it? What can you do? What can she do to get it out?
No, I certainly think because this is so new, this is not in everyone's hands quite yet. So, I mean, we would really appreciate your help in sharing this with all the clinicians that you work with, and certainly kind of take from it a lot of these key points, and certainly add the things that you know from your experience caring for these patients as well.
And I would add that, we're working with some clinicians across the country for the U.S. Pregnancy After Loss Network, and I know that some of those clinicians don't know about this toolkit yet. So I would guess that it's brand new, and it has not gotten out to many people who could make use of it yet.
Yeah, I would say, so I just double checked, you definitely don't have to be a member. It's a little hard to find. The way I found it every time is if I Google an ACOG Stillbirth Toolkit, that brings you to a Compassionate Conversations webinar, caring for patients experiencing stillbirth, which is a conversation that I moderated between a couple folks who helped design the toolkit and some other folks as well. And then on the resources tab of that page, you can find this toolkit among with other things, but all of those are available to anyone.
Thanks.
That being said, I think that is good feedback that we can make sure gets back to them, that we can put this in a better, more centrally located place that isn't difficult to find, because we want everyone to have access to it.
For sure. Other questions? Okay, yes.
Do they have people that provide training for this already?
Great. So the question is whether ACOG has people who would provide training for this toolkit to providers.
Yeah, I think, and I don't want to speak on their behalf, Sheila would probably be able to answer this better, but my understanding is with kind of the removal of the funding source, it might be difficult. A lot of these teams are very small, but I think certainly something that we can look into, and certainly Karen and myself will certainly have particular interest in this area, and I think we can certainly collaborate with ACOG and hopefully bring these trainings out to institutions like some of the other trainings that occur through ACOG.
We're actually having a session later today, sort of a brainstorming session about actions that we can take to provide equitable bereavement care, and it strikes me that, you know, this toolkit could play a role in that, and, you know, what is the role that our community can play in getting this into the hands of folks who can maybe use it, as well as providing basic training, you know, stepping into the breach, as it were. Yeah. Well, thank you very, very much, Michael and Karen, for being on. Really appreciate it. And also, I think very much we're grateful to know that ACOG is very interested in getting feedback from us all, from you all, as you try to implement the toolkit or use it. So that also could be something that our center could help with, is sort of funneling, helping to facilitate feedback going from providers to ACOG. I think.
Yeah, and thank you all for the work that you do. We really appreciate it. It's certainly a team effort when we're trying to tackle this large topic of stillbirth.
Thanks so much. Okay, session that we have, I'm just going to bear with me for one moment, is entitled Messages from our international partners. And I'm going to share a couple of slides and then some messages. So hold on just one moment.
Doing great, Susanna.
Let's see.
When Zan pulls up her checking account, 3
Okay, so I'm just winging it on this. I pulled these slides together, a few slides together last night. And I just wanted to orient us. We've been talking a lot about the situation in the United States in terms of stillbirth, stillbirth numbers, stillbirth equity and inequities, and stillbirth bereavement care. But we're very, very lucky to have amazing colleagues around the world and wonderful work that is being done in other countries that we can learn from. And so I just wanted to share a few slides to orient us. The Utah Stillbirth Center of Excellence, USCO, has 8 founding partners around the world, including from Australia, Ireland, the UK, and so on. And each of those founding partners, or many of those founding partners, have great expertise in bereavement care. And also, not just those, not just the founding partners, but others around the world. So, on the screen are 2 sort of bereavement care pathways, I'm going to call them. On the left is a screenshot of the cover of the bereavement care pathway from Australia that you've heard about already today a bit. And on the right is a website from the Government of Canada, thank you very much, on loss and grief. And this is a wonderful resource. All the links are available on our website under the Resources tab. And here we have, on the left, the national standards for bereavement care in Ireland, and on the right, the National Bereavement Care Pathway in England. On the left, in Portuguese and Google translated to English, is a news release from Brazil. This is just a few months old. A law was passed, a federal law, on perinatal grief and bereavement care and the recognition of stillborn babies by a wonderful colleague in the Stillbirth Advocacy Working Group. And on the right is the ACOG consensus statement on management of stillbirth that Michael was mentioning briefly before. I'm not going to, there are 2 slides here, and I'm just going to tell you what's here, but not go into any detail. This is a comparison of some basic characteristics of some of the national bereavement care pathways that are out there in the world. You can see the columns are for Australia, Brazil, Canada, Ireland, the UK, and the US. The first row just shows the number of stillbirths in each of those countries, and the second row has a hyperlink to the relevant document. I showed you the covers of those documents in the prior slides. The next row just mentions what the entity is. Some of these are clinical practice guidelines that are signed on to by entities such as ACOG. Some are laws and some are standards. You can see how recently these were all updated, all just a couple years old. And then you can see which organizations actually created these guidelines. Australia's was created by the Perinatal Society of Australia and New Zealand, together with our founding partner, the Stillbirth Centre of Excellence. Some of the others were created by federal governments of Canada and Ireland, and so on. Most of them are national in scope. The ones with national healthcare are endorsed by the federal government. Some of them are endorsed by professional associations. You can see the great variety in the length of these guidelines. The one from Australia is over 300 pages long. Most of them address both stillbirth and newborn death. And then this just gives an overview of whether there was parent involvement in the development of the guideline, whether there is a parent version available. The only country where there is such a parent version is Australia. Whether there's training available to implement the guideline, whether there are other tools available that kind of go along with it, a checklist, etc. Is it evidence-based? Yes. And then you can see information about the contents. I'm not going to go in, I don't have time to go into the details, but there is a lot of overlap in terms of content areas, but then there are some standout content pieces. For example, the guideline from Canada focuses in part on supporting providers in providing care. So I just wanted to give you that snapshot before going to some pre-recorded messages from two of our founding partners in Ireland and Australia who couldn't be here today, and they also can't be live given the time zone issues. So hold on.
Hi everyone, I'm Equitable and I'm here with my colleague Dr. Siobhan Mockman, and we're from the National Health and Medical Research Centre of Excellence in Stillbirth, and we want to talk to you today about the work that we've been doing to improve care after perinatal loss in Australia through our National Perinatal Loss Care Pathway. Just a bit of background about us. So the Stillbirth Centre for Research Excellence was established on the back of many years of work in 2016 to conduct a priority-driven program to address the neglected problem of stillbirth in Australia. And our vision is to reduce the devastating impact of stillbirth for women, family and the wider community in Australia and across the globe, working with the International Stillbirth Alliance. We have 4 priority areas that you can see there, and cross-cutting areas of equity, diversity, co-design very importantly, and community awareness. But today we'll talk a little bit about the work that we've been doing in priority area 4, optimising bereavement care. We've worked very hard to engage all the stillbirth community in the country as much as we possibly can. We come with different lenses, different experiences, bereaved parents, researchers, clinicians and policymakers. And we have a vision though, and the central vision is to improve outcomes for families. Parent advocacy has been really important in the work that we've done, and political advocacy. We've been very, very fortunate to have both parents and politicians working with us. And this is, an example of this is the Stillbirth Senate inquiry. And you can see the input from bereaved parents here. That was the submissions, the number of submissions received there on the slide. Overwhelmingly, the voices of parents and grandparents really shaped the vision of this country in addressing stillbirth. I just want to acknowledge Christina Keneally there and Senator Melannie McCarthy, who were both touched by stillbirth, who led this inquiry, and all members of the committee undertaking this inquiry had stillborn babies within their close family. So the National Stillbirth Action and Implementation Plan was born in December 2020 with a vision to reduce the numbers of stillborn babies, to raise community awareness and understanding of stillbirth, and to improve bereavement care, all with the lens of equity. Our work has continued in the Stillbirth CRE, engaging parents in the very heart of all we do. And this slide shows the recent research priority setting exercise that we did, where we engaged 300 participants. Around 50% of those were parents, the rest were policymakers and clinicians and researchers. And through an extensive exercise over a 3-year period, we finally distilled out 6 priority areas to guide our research into the future. They're available on our website for those that would like to look a little further. We established a parent registry to ensure that parents remain involved, and we've got now over 300 parents on the registry and 130 assigned to a research project of their interest to work side by side with researchers. And to help them to get involved, to know where to start, we developed a booklet, a guide to research for bereaved parents, and that's available on our website, just to really help kickstart those parents who really want to get involved in research and how they might go about it. It might be nice to share a little bit about the road to now. It's been a long journey. In 1996, we first established a perinatal mortality group as part of the Perinatal Society of Australia and New Zealand. We focused on improving the quality of data, trying to get the truth on why babies die, and published our classification system that's now used widely across the country in 2000. We've had 3 updates, an expansion of our best practice guidelines on perinatal mortality audit, the most recent one being in 2024, and I'll hand over to Siobhan to tell us a little bit more about that.
So we released the Care Around Stillbirth and Neonatal Death Clinical Practice Guideline last year in 2024, and this was the first edition that was approved by the National Health and Medical Research Council, which recognised these as best practice care recommendations in Australian healthcare settings. And to support implementation of this guideline, we've developed a range of resources and tools to support health professionals and services to provide the best quality care that they can. So our main implementation strategy is through our National Education Program Improve, which is also now being expanded and enhanced to align with the guideline. And we also have a range of parent resources to really support parents and guide conversations with their healthcare team. So the Guiding Conversations booklet, which was also adapted for Aboriginal families due to the Peppermint Star Baby. And recently we released 2 new resources, one for early pregnancy loss and one for care and subsequent pregnancies. And we've also just developed a new online program called Caring for the Carer, which aims to support healthcare professional wellbeing in this space. And these resources and tools have all been informed by a range of national landscape surveys, so that we're really hearing the voices of bereaved parents, health professionals on the front line, and maternity services and other stakeholders. So for example, one of those surveys that we did a few years ago was looking at alignment with best practice care recommendations by maternity services. And you can see in the purple there that most felt that they were providing good care, but that there was still room for improvement, with only 5% really perceiving their care as not needing improvements. The Improve program, which we mentioned just before, is our main implementation strategy for implementing the guideline. So we're now just working on the expansion and enhancement of that to include some of the new topics and focus areas in the 2024 guideline. So we expanded the perinatal loss care chapter to include early pregnancy loss and miscarriage. We also included new chapters on perinatal palliative care, care and subsequent pregnancies, and also the importance of healthcare professional wellbeing. So Improve's available as a face-to-face workshop and as an e-learning program, and it's trained over 7,500 healthcare professionals across Australia, and it's been rolled out internationally, and we're very pleased to be working with the Utah Centre of Excellence in Stillbirth to provide this education program to the US. Just one of our other examples, so this is an online grief support program for parents, and it's available to any parents who has experienced the loss of their baby during pregnancy or soon after birth. It's a range of different flexible modules that can be completed, and we evaluated the program to make sure that it really was meeting the needs of parents and families, and it's now rolled out nationally and has been really well received by the bereaved community. And that brings us to our National Perinatal Loss Care Pathway. So over the last few years, we've worked really closely with stakeholders across Australia to really design and develop something that was really going to meet the needs of all of everyone involved in perinatal loss care. So this pathway aims to close the evidence practice gaps and connect care across the continuum of perinatal loss. So from the time of diagnosis, a real focus on that critical transition from hospital to home and ensuring families are connected to ongoing support in community settings, and right through to care and subsequent pregnancies, early parenting and beyond. So we're going to bring all of these resources, tools, guidelines, the clinical care standard that we have in Australia into a centralised digital portal. So it will cover the entire perinatal loss continuum and provide a central place for health professionals, parents as well, and services to go to have access to best practice care, tools, resources, and also looking at developing some sort of assessments and ways to support services to improve in areas that they identify as needing a bit more work. And most importantly, developing really clear referral pathways to connect families across that continuum between services and health professionals. So this is a truly national initiative, and we're so pleased to have all Australian, state and territory health jurisdictions, departments of health involved as partners. We've also partnered with parent support and advocacy organisations, professional colleges and professional organisations to co-design and develop a pathway that's going to really create meaningful change for families in Australia. And we're really pleased to be working with our international collaborators and partners as well to align our pathways and ensure best practice care.
We'd like to say thanks for having us as part of your symposium, and look forward to working with you across the US to improve care for families, and always happy to take any questions via email. So I'm sure Susannah, Leisher, others will broker any further questions you may have of us.
And we'll see you next year.
See you next year.
Great. Okay, so that's the first of two, and all the resources that Vicki and Siobhan mentioned are available on our website. We'll share those links. So I think we're really lucky that we have so many wonderful colleagues who are thinking about us right now, and the work that we're trying to do as we consider how to do better at providing equitable bereavement care. And there's so many amazing tools, of course, in the United States, across Utah and around the country, but also outside the country. this morning Sue was telling us about the adaptation of the Guiding Conversations booklet, which of course is a resource from our Australia colleagues. There are so many resources out there, some of which could be used, right now, or could be adapted gradually to be fit for the purpose of care provision in the United States. So. Our website, our center website, has hyperlinks to all of these sites and resources, and we hope that you are able to make good use of them.
Thanks to everyone, great day, and I thought there were some really great ideas that came up in that recent session, and so many really good things. I think a lot of people are already doing a lot of those things, and I've been inspired to do more of them. I think one way to get something done is for people to do some of those things, and then if they're successful in reaching some folks in rural areas or some folks that haven't had access, to then publicize that so that we can take what works and then export it and have it be done in more places. And so I think there's a terrific role for that. So I want to thank people. That's part of what we want to do. So thanks again to our sponsors. We extend our heartfelt thanks to the generous donors and sponsors who have made this gathering possible. I want to very specifically thank the Maurer family, whose gift is given in loving memory of Riker Mulholland. I also want to thank the Stetler family for their amazing work, and to our corporate sponsors, Young Living, Cozy Earth, the Grand America Hotel, and the Larkin Mortuary. To all our sponsors, we are deeply grateful. I just want to reflect on, how proud I am about this conference and the work that you all are doing. And I apologize for not being here earlier. I was taking care of patients, and it's been a little bit of a juggling act. But I saw a couple of patients today who just really reinforced to me just how valuable all the work that you're all doing is. And I saw someone who literally had 8 pregnancy losses, a couple of second trimester stillbirths, most dramatically a neonatal death, where she had a classical cesarean and then had her baby survive for a while, and just recently had a live birth. And we did some medical stuff, but most of her journey was really the emotional support that she had from a lot of our peer-to-peer folks and from the community, giving her hope and allowing her to kind of get through this. And then later I saw another patient who was 6 weeks out from delivering a pre-viable infant who suffered a neonatal death. And that was the sad part of this. But she was so grateful for the experience that she had, because she felt so supported by our nurses and our clinicians, and also by peer-to-peer support. And because of people like you, she had a bunch of mementos of her baby. And they just kept talking about how happy and grateful that they were that they had these mementos, and they've shared these mementos with their family. And they were thinking about, maybe we ought to just kind of go to sleep and have a D&E, and they didn't want to get near, actually going through the birth process. But they couldn't have been more grateful, and they were just so thankful for the emotional support. So I get to see the day-to-day positive impacts of the stuff that everybody here is doing. You may not see it day-to-day, but I promise you it's going on. So please keep doing what you're doing, and thank you for doing what you're doing. So now we are going to present our second annual Stillbirth Champion Award. Last year the award went to Debbie Haynes with her dedication to stillbirth prevention research and to federal advocacy and getting the Shine for Autumn Act passed. It looks like it may actually even get funded this year. Deb is a tough act to follow. But this year's Stillbirth Champion Award is going to Dr. Lupe Aguilera. So let's hear it for Lupe. Lupe, we're going to embarrass you a little bit here. So Lupe holds a PhD in sociology from the University of Utah and is a social demographer by trade with postdoc training at the University of Wisconsin-Madison, and just as of this week has an appointment as adjunct faculty here in our Center of Excellence. Her research interests include refugees in stillbirth and family well-being after stillbirth. Lupe is special because she makes us think about wider groups of people affected by stillbirth. Her personal experience of being not only the aunt of a stillborn baby, but also the sister of a stillborn baby has driven her passion for her research focus on the impact of stillbirth on entire families rather than just the parents. This really makes us think about the burden of stillbirth in a much bigger way. It's not just babies who die and their parents, but siblings, aunts, and uncles who are affected. Don't forget grandparents. Lupe has enthusiastically and wholeheartedly engaged with the stillbirth advocacy and research communities over the past several years, taking on roles in the U.S. Stillbirth Advocacy Working Group, advocating for stillbirth education, at the Mexican Consulate, and community groups promoting advocacy and education for Hispanic and Latinx families. So congratulations to Lupe. So,
you know what, just a second, sorry, Lupe? Do you want to come and say something? Come. I know I'm putting you on the spot. Totally on the spot.
No, I don't know, just thank you so much. It's been, it's such a welcoming community, and I loved being part of SOG and working with everybody and kind of stepping into working in this area. There's, you know, my family history of this happening, and it's been a journey, I guess, of professionally stepping into this area, having known like personally what the impacts are, and thank you so much. Okay.
So I'm going to screw up this next part, even though Zan's trying to help me not. But I want to thank everyone who made this day happen, because it's a ton of work. So thanks to the team: Leanne, Lejeune, Sue, Stacey, Sarah, Ashley, Inez, Danae, Ann, Des, and Zan. Let's hear it for Zan. If Zan wasn't a crazy Energizer bunny, none of this stuff would happen. So, I also want to mention that, believe it or not, this is our off year where we're not really having a conference. But next year we will have a more official conference. So we'll have some international partners. We hope to do Improve Again and the US PAL Network Learning Day. So thanks again.
Talking about data collection, right, and the importance of data collection. And so everyone needs to have this on their radar. The Shine for Autumn Act is still trying to get passed. She was our award winner last year, Deb, and we are working on it this year. So if you have had a stillbirth, or if you want to be involved, Deb is trying to do a survey to collect data on the financial burden of stillbirth in families, and this is crucial to help us just have insurance companies come on board and really put a number to these issues. So this is really important data. I know we've said we'd put everything on our website and link and probably in an email, but it really takes like 5 minutes to fill out her data collection, and she's really, I think we have 20 families from Utah that have filled it out, and we are leading the country. So if we're leading the country with 20, we really need to help her out and get this filled out, because it makes a big difference. So, please join us again next year for Closing the Gaps. We want to close out this day with a beautiful song. I still can't look at her. Sung by Haley Fletcher, my sweet daughter. The song is I Know Where I've Been from the musical Hairspray. I chose this song because it fits so well. And I made it all the way through. And our theme today of light, inequalities, awareness, determination for change. We know where we have been concerning healthcare inequalities and challenges. May we leave today going forward with new determination and awareness to help each other more as good humans and friends. Following Haley's song, we'll have a 30-minute break before our evening workshops. If you have signed up, or I think we have probably enough spots that more people can attend, but we'll do a quick pizza dinner for those that signed up and want to stay, and then we will do a bereavement photography workshop and a molds training and refresher. Everyone will get a little packet and learn how to do molds. You get to do your own, so please stay if you can. And then Shirley's gonna end us the evening with a sound bath for us to just relax and decompress from this day. So it will be an amazing evening if you can stay. So I will turn over to Haley. Do I just stand here? Okay. Give me your phone though, so it doesn't yell at you. Okay. Oh, you need your phone. Well, no, you don't. You've got that.
Okay. Please give me grace. Haven't sang this in a good year and a half, so. There's a light in the darkness, though the night is as black as my skin. There's a light burning bright, showing me the way. But I know where I've been. There's a cry in the distance. It's a voice that comes from deep within. There's a cry asking why. I pray the answer's up ahead, 'cause I know where I've been. There's a road we've been traveling, lost so many on the way, but the riches will be plenty and worth the price we had to pay. There's a dream in the future. There's a struggle that we have yet to win. And there's pride in my heart, 'cause I know where I'm going. Yes, I do. And I know where I've been. There's a road we must travel, lost so long. There's a promise we must make, 'cause the riches will be plenty and worth the risk and the chances that we take. There's a dream in the future. There's a struggle we have yet to win. Use that pride in our hearts to lift us up till tomorrow. 'Cause just to sit still would be all